Again, good morning. Welcome to our webinar. And I would like to thank you all for joining us and turn it over to Dr. Leandra Mina.
Thank you, Sergi. And good morning and welcome to the Enhancing Disease Investigation and Intervention Functions meeting. For more than 40 years, disease investigation specialists, contact tracers, have helped in the response to infectious disease outbreaks. They are integral components of STD, tuberculosis, and HIV prevention and control programs around the nation. They have also been called throughout the years to respond to emerging threats like Ebola, Zika, as well as outbreaks and clusters of hepatitis A, C, and HIV. Their unique skill sets and role in intervening in the spread of diseases came into the spotlight in 2020 as a critical component of our nation's response to the COVID-19 pandemic. Some would say that they represent the boots on the ground of public health. In the next 3 days, we aim to unpack characteristics of disease investigation and intervention functions in the context of public health priorities. We're opening a scientific discourse that we are hoping will help us identify knowledge gaps and areas for further research inquiry. We see this meeting as the beginning of a conversation which we are committed to continue in the months that follow. Next. Before we continue, here are some meeting rules for the next 3 days. In the interest of time, we have minimized the chair function. To each speaker, please introduce the next speaker by name only. A speaker's background, information, and institutional affiliation are in the bio package that was sent to you. Please put all comments, questions, and suggestions about knowledge gaps in the Q&A box. This will be addressed during the panel discussions and Q&A session on Friday. We do not have a chat box to minimize distractions, and for technical difficulties, please contact Tony McDuffie at 240-614-9293. Next. Finally, I would like to give my profound thanks to the organizing committee led by Dr. Sergi Aral for the many hours of thinking through these issues, preparation, and development of an agenda that promises a thought-provoking meeting. Now, without further ado, I would like to introduce our first speaker. Next. Dr. Matthew Hogan will talk about enhancing DS functions and present our cognitive framework.
Good morning, everyone, and speakers, panelists, and attendees. I too welcome you to this DIS meeting. We anticipate we will make great strides toward increasing the impact of disease intervention services through our collaborative efforts over the course of this week. I'm going to spend just a few minutes outlining the thinking to which so many have contributed thus far, what we are calling a cognitive framework for this meeting. I do emphasize the we, as Drs. Aral, Golden, and many others that Dr. Maynard has just listed, are the reason that this framework exists. Next slide, please. Thank you. I present here a detailed roadmap of how a public health program might operationalize DIS activities. These would not be confined to STD and HIV, although of course you will recognize the application of the activities listed here. I shan't dwell on the details as our colleagues will soon be speaking to this model in more detail. However, I shall note that we begin here with public health priorities applicable to infectious diseases, communicable diseases other than HIV and STD, as abbreviated as CD on these slides you will see on the left side. You will recognize our priorities as finding and managing infectious disease for infected persons and for those exposed. The list of activities in which DIS may be involved, that would be the central box here, is extensive and of course varies by program. We have acknowledged that the outcomes for all these activities are incompletely known, that would be the third box over, and this is one reason for this whole meeting. We might be unclear on efficacy, on relative value, or on population impact. We are here to grapple with this issue and be sure the results of doing so are reflected finally in a performance measurement as represented by the box on the far right. Next slide, please. Thank you. On this slide, I present to you an enlargement of our cognitive framework. The contents of the previous slide flow left to right through the middle of this one. So the new domains are largely context for the activities. Again, I shall not dwell on the details as each domain will be presented and discussed in the sessions to come. Instead, let us note that the context adds more feedback loops and requires an iterative approach to increasing impact. Importantly, our public health priorities remain drivers of the entire cognitive framework. You will see they are the only independent sort of measure in this whole diagram. Next and final slide, please. Thank you. I'll end by acknowledging that this cognitive framework exists in its own essential context. Although we have, after considerable thought, kept direct attention to recruitment, retention, and training outside the scope of this DIS meeting, we acknowledge here that these three aspects of disease intervention work are vital to the full development of the workforce, and I include the people who compose that workforce, and to any success that we achieve through our work this week. So, in closing, I thank you for your attention, and we'll now turn to the next presentation delivered by Dr. Matthew Golden. Thank you.
I'd like to thank the organizers for the opportunity to give this talk, particularly Dr. Aral. I'm going to be talking about defining the role of HIV/STI field services in the COVID and post-COVID United States, taking an HIV/STI perspective. I want to organize this talk really around one question, which is, what work do we want the DIS to do? Traditionally, the DIS have been very focused on HIV/STI case finding. But there are a lot of other things that they can do and often do, including collect surveillance data and disease investigation, do work related to linkage to HIV care and relinkage to HIV care or data to care, linkage to PrEP, and of course, most recently, contribute to surge capacity in an emergency related to COVID-19. Before I get into this question, I want to make sure we have some common terminology. Throughout the talk, I'll be using the term index case to refer to people diagnosed with HIV or an STI who receive partner services, and the term assisted partner notification services to refer to the activity of medical or public health people interviewing people with HIV or STI to identify their sex and needle-sharing partners, and then offer those index cases help notifying their partners, ensuring their testing and linkage to care. We have developed a large number of metrics for assessing partner services over the last 7 or 8 decades. Among these are the brought to treatment index, which is the number of new syphilis diagnoses in partners divided by the number of index cases who are interviewed, or for HIV, the case finding index, which is the number of new HIV diagnoses in partners divided by the number of index cases that are interviewed. 1 divided by the case finding index is the number needed to interview. It's a little more intuitive. And what it's basically telling you is how many people do I need to provide partner services to in order to identify 1 new case of syphilis or HIV or another communicable disease. So our randomized controlled trial data and controlled trial data for partner services are quite limited. We have a single randomized controlled trial of APF conducted among 74 people with newly diagnosed HIV infection in North Carolina in the late 1980s. That study showed that 50% of partners of people who received APS were notified versus only 7% of those who did not receive the intervention. But whether or not that experience from that trial is germane 30 plus years later, I think is uncertain. Beyond that, we just have a couple of controlled observational studies. One was conducted by our group in Seattle, which looked at a retrospective study of people with HIV infection, which showed that APS recipients reported notifying more partners than non-recipients. A study in New York City compared 2 time periods and showed that the provision of public health APS increased the number of partners known to be notified versus just relying on medical providers. For bacterial STIs, we have no randomized controlled trials or controlled studies of APS for syphilis, where a control group did not receive any intervention. We do have 2 randomized controlled trials looking at male STD clinic patients with urethritis, so only one of those was published. And that did show some evidence that the work of DIS increased partner treatment. So in the absence of a more robust body of literature with control data, what we're left with is relying on more routine program statistics. On this slide, you're looking at case finding outcomes in 2019 for HIV partner services in 13 jurisdictions that are participating in phase 1 of the End the Epidemic initiative. In these jurisdictions, almost 19,000 people were newly diagnosed with HIV infection, of whom almost 10,000, 9,733 or 52% were successfully interviewed. The case finding index was only 0.05. So 516 partners were newly diagnosed with HIV. What that means is almost 20 people, 19 people, had to receive partner services in order to identify one new case. Now, I think it's important to realize that this is likely something of an overestimate because at least some of these people were notified and tested before the index case even received partner services. And additional people would certainly have been notified and tested in the absence of the intervention. Looking at the productivity of DIS overall, the median number of new HIV diagnoses per full-time DIS in 2019 was only 1.8. In other words, a typical full-time DIS would identify fewer than 2 new cases of HIV per year working on providing HIV APS. On this slide, you're looking at the case finding outcomes over time. And I think this helps explain part of why we're seeing a relatively low level of case finding. You can appreciate in both in the United States and in the United Kingdom, the case finding index has been steadily declining over time. Something that I think the DIS who are listening to this talk have experienced in their own lives and have an intuitive sense of. The same thing appears to be true of syphilis. A literature review conducted of studies between 1995 and 2003 saw that the brought to treatment index during that time period was 0.22. Between 2015 and 2017, in 7 jurisdictions in a CDC study, that had decreased to 0.15. But if you then limited that to the partners who were treated at the time of the index case or in the subsequent 30 days, it was cut almost in half. More recent evaluations, which are unpublished from King County, North Carolina, and Florida, all confirm that the brought to treatment index is roughly half of that observed 2 decades ago. So overall, I would say that the evidence supporting assisted partner notification services for HIV and syphilis as a case finding strategy in high income nations is weak. It likely identifies less than 5% of all cases of HIV infection and less than 10% of early syphilis cases. It's probably somewhat more effective in women and among heterosexuals than among men who have sex with men. And it may play an important role in outbreak response. But I think despite that, what these data really do is they beg the question, what are we really trying to accomplish? And I think that the APS system can do very much more. So one thing that partner services do for us is they have the capacity to improve our surveillance data. Ideally, case investigation and partner services are part of an integrated process. Among the things that this accomplishes is it refines our estimates of how many new HIV diagnoses there really are. If you look at the figure on the right of this slide, what you're looking at is the annual number of new diagnoses in King County between 2013 and 2020. If you include and do not include prior diagnoses that are only identified through the partner notification process. What you can see is that in the absence of integrating partner notification data into the surveillance data, you'll have a roughly 20% overestimate of the number of new diagnoses every year. Of course, this is not the only bit of information we're getting. We're getting information on homelessness, on substance use, on where in a county or jurisdiction people live or where they reside if they don't have a permanent place to live, whether they previously used PrEP. What are the missed opportunities to diagnose HIV in the community? All of that information is available potentially through partner services. But the question is, are the health departments really collecting those data as part of APS? And then is there really the bidirectional integration of surveillance and disease investigation, which is necessary to make that useful? APS can also play an important role in outbreak identification and response. Here we see an example of a cluster of HIV infections, an outbreak that was identified among heterosexual people who use injection drugs who were living homeless in King County in 2018. On the left hand of the slide, what you see is using molecular surveillance. These cases were moving along at a slow pace over a number of years. began to accelerate in 2018. We became aware of it, though, in August of 2018, when an astute disease investigator brought this to our health department's attention that we had an unusual cluster of cases. And this triggered big expansion of syringe services and outreach testing and testing in our jails, which subsequently led to the end of this outbreak. Of course, we are not the only ones experiencing outbreaks in people who are inject drugs, and there have been outbreaks really all over the United States since 2015 in these populations, which is very important, and the disease investigators have played a critical role in our response. Partner Services also has the potential to improve linkage to HIV care. We have 2 observational studies supporting this. The first was conducted in New York City between 2007 and 2013, and found that people who had received APS were more likely than non-APS recipients to link to care at 3 months, 79% versus 60%. A second study conducted in King County, Washington, showed that linkage to care likewise increased, which is shown in the figure. And at 3 months, 90% of APS recipients had linked to care versus only 81% in those who had not linked. Now, these are not randomized controlled trial data, but this difference does appear to persist with adjustment. Partner Services can also potentially play an important role in relinkage care. Again, these data come from New York City. Here, we're going to concentrate on data that were collected or partner verification done between 2015 and 2018. Now, during that time, New York City had almost 7,500 new HIV diagnoses and interviewed over 6,300 people, index cases for APS. Those people named 2,293 partners. Of whom over 14 had an unknown status, leading to 150 new HIV diagnoses. Now, again, this case finding index is low, lower than what I even showed you before, only 0.02. But they also had over 850 previously diagnosed people, of whom almost half were not in care or were viremic. So if you had something called an out of care index, that was 3 times the case finding index. What this suggests is there is an opportunity here to use HIV Partner Services to improve relinkage. The same thing appears to be true of syphilis. Here, what you're looking at is data collected from multiple different jurisdictions between 2016 and 2017. So these data come from Louisiana, Michigan, Mississippi, Oregon, Rhode Island, and Texas. During that time, 39% of people with early syphilis were HIV positive, of whom 26% were out of care and not virologically suppressed. To me, what these suggest is that there's a substantial potential to use STI Partner Services to promote relinkage to care. At the same time, it's uncertain if relinkage to this mechanism will be effective. Relinkage is hard. It's not enough just to find people. That's necessary, but it's not sufficient. And this slide really tries to emphasize this. So these are data from a step wedge cluster randomized trial of data to care, where we attempted to relink people who had been out of care and then looked at viral suppression following this effort. What you'll see is there was absolutely no impact in this trial of the data to care outreach relinkage intervention on subsequent viral suppression. I think what this really emphasizes is that DIS outreach is not a solution to the problem of inadequate population level viral suppression. It's part of a solution. And field services need to be seen as part of a larger public health strategy. Our approach in King County with this is to have developed sort of parallel systems of field services outreach, which exists as a continuum from when people are initially diagnosed, so expanded case investigation, to pharmacy-based identification of people who are stopping ART, to real-time data to care where we're identifying people in emergency rooms, and hospitals, and jails, and through STD Partner Services, and then linking that to a system of differentiated care, which includes not just our conventionally organized HIV care model, but also clinics which are specifically designed to serve the needs of the patients who have struggled the most to stay engaged in a conventionally organized medical system. There's also an opportunity to use partner services for PrEP. These data, again, come from King County, collected between 2014 and 2020. During that time, we had almost 6,800 people who were HIV negative MSM interviewed for partner services. We collected data on 89% of these people related to PrEP. 50% of the people were already on PrEP, and you can appreciate that this number increased over time. There have been roughly 3,000 people who were potentially eligible for PrEP referral. 63% were offered referral. And I would point out that early on in this program, we didn't offer it to everyone, but we do currently offer these referrals to all MSM who are off PrEP, of whom 67% accepted the referral. And of that group, 56%, we believe, initiated PrEP. What that means is that approximately 1 in 3 HIV negative MSM who are not on PrEP will start it when PrEP linkage is built into STI partner services. What I'd say overall with this is that, like relinkage to HIV care, linkage to PrEP requires a clinical infrastructure that is integrated with the work that DIS performs. There are a lot of different infrastructures that can probably work. Sexual health clinics are part of that, but they don't have to be the only way that we do this. But I think, again, this emphasizes field services are part of a larger public health strategy. They really cannot be seen in isolation, particularly as we consider these expanded roles for our DIS. So in summary, what I've tried to show you is that our partner services efforts, our investigations can improve linkage to care, that they can improve our surveillance data through decreased misclassification and identification of outbreaks, that they have the potential to improve relinkage to care, though that has not really been proven, and that they have a big impact potentially on linkage to PrEP. For all of these things, except for the PrEP linkage, the public health benefit of each activity is likely small. But I think we need to consider all of these outcomes in aggregate and implement these diverse activities as a single integrated program. Now, I've been talking about all these traditional HIV STI things, but of course the elephant in the room is always COVID-19. The COVID-19 epidemic really demonstrated the inadequacy of our public health infrastructure. We didn't have enough staff, we didn't have the resources we needed to rapidly respond to a massive pandemic, and our capacity remains a problem. At the same time, at least in our experience in Seattle, HIV STI DIS were the staff who were probably best poised to rapidly implement COVID-19 contact tracing. And it was those DIS who became our trainers and our supervisors as we built the COVID-19 contact tracing team. The problem is we didn't have enough of them. We now have new federal resources going into building DIS capacity, and surge capacity to respond to outbreaks needs to be part of DIS work. So the DIS teams need to be engaged. There are, though, a number of challenges with this. Among them is that the DIS teams need to be engaged in high priority work, even in the absence of a pandemic, but then have that capacity to shift their work rapidly in the event of emergency. What I've been trying to address here, and with something we'll have to be addressing, I think, throughout this conference, is what is that priority work going to be? There are also, in some instances in my experience, philosophical differences between HIV-STD and some other communicable disease programs. So what is the role of public health, in particular in direct service provision? For HIV-STI, much of our work is really almost case management sort of work, linking people to medical services. But that is not always the case for other aspects of communicable disease. And we'll need to navigate what we want to accomplish here. I also want to point out that our teams require more than just DIS. Building successful new teams is going to require additional leadership, supervision, epidemiology, data management, and human resources. So in conclusion, I say that HIV-STI field services remain an important component of public health disease control activities, including activities related to HIV-STI. But the case finding alone cannot justify our investment in field services in the United States. We need to modernize what DIS teams do, and that's going to include new bodies of work related to improving surveillance and outbreak response, linkage to care, PrEP and other services, and surge capacity. This will require new organizational structures that more closely integrate DIS with epidemiology and data management and new technologies. I think that success will require a more holistic view of public health and clinical services, one that conceptualizes field services as part of a larger public health and clinical system. And last, I would say we won't always get this right. We need to be committed to experimentation and learning from our successes and failures. And overall, if everything you do works, you aren't taking enough risks. So it's okay to fail sometimes. That's my last slide. And so I'm going to hand the microphone over to Lupita Jones. Lupita, thank you for being here.
Good morning, everyone. I'm so honored to be here to speak to you this morning about the role of disease investigation intervention specialists in other communicable diseases. I just want to thank Matthew. It was very interesting, the data he presented on New York City, which I wasn't familiar with. But I did start, I'd like to say, in HIV. I worked 11 years there before I moved to communicable disease, where I've spent the last 17 years. Next. So I'd just like to start with a little background on the New York City Department of Health and Mental Hygiene, background about my unit in communicable disease, talk about how we activate and how we incorporate DIS staff into our emergency activations, specifically during COVID, and then some lessons learned. Next. Okay, so to start, a little background on DOHMH. We are one of the oldest public health agencies with over 200 years working leadership. We are one of the largest public health agencies in the world as well. We serve over 8 million residents in New York City, and it's a very diverse city, ethnically and culturally. We tackle a broad range of issues, chronic, active bioterrorism, everything that every health department has to tackle, as well as a lot of emergent infections, being a global city and a big travel hub. Next. Okay, so within DOHMH, there's about 10 different divisions, and my division of disease control is one of the 10. You know, others include epi, bioterrorism, emergency prep, child health, and others. But I'm going to talk about what we do in disease control. So prior to COVID, on the left, you see that's how we were organized. So communicable disease was separate from HIV, STI, TB, and immunizations. They decided, leadership, to reorganize this before COVID, and we actually implemented this in July, which was a bit of a challenge in itself with changing staff and doing all that in the midst of COVID. But what we now have is they pulled viral hepatitis from our communicable and merged that with HIV and STI into one bureau. And then they took all the clinical labs, the TB, immunization, STI clinics, and merged them under a new bureau, public health clinics. So that's how we're organized now. Next. Thank you. So within communicable disease, we have several units. We have a unit that's just foodborne. We have a zoonotic unit, antibiotic resistance, as well as our data analysis unit and admin. And of course, my general surveillance unit. So staff in my unit conduct the investigations for all other units. So even though there's a special foodborne and zoonotic, the investigations are handled by staff in my unit. So in communicable, there's about 75 diseases reportable to us, and that's everything except for TB, HIV, STI, and the vaccine preventable diseases such as measles. So all other communicable diseases are reportable to BCD. My unit, the general surveillance, actively investigates 37 of those diseases routinely. My staff, the staff in GSU, are comprised of MDs, nurses, research scientists, mostly public health epidemiologists. One thing in other programs like HIV and STI, they utilize titles called public health advisors. We don't have that title in Communicable. We use public health epidemiologists because it's a little more complex, having 37 diseases that staff have to investigate, as well as outbreaks. So we use that level. And basically, they do the same thing. They're our disease investigation / intervention specialists. Next slide. Okay, so this is just an org chart so you get an idea of the staff in the General Surveillance Unit. So the first line is our data support, our clerical support. And then we have 3 supervisory teams of case investigators where they're located, well, they're assigned geographically. So each team gets a different section of New York City to investigate those cases. We have, if you see some of the light, I guess, green color, are new positions. We had about 4 new positions thanks to COVID that we got, and we were able to promote staff into supervisory lines, which was much needed. We needed more support because we're losing a lot of staff. We have about 4 staff that will be retiring by the end of the month. Next slide. Okay, so this is just example of, just wanted you to see the types of diseases that staff do investigate in Communicable. So we have a very diverse group, diseases. So any disc assigned to us, so while we're looking, we'll get a good cross training, because in disease investigation, in disease intervention, because a lot of our diseases are not just investigating, but, coordinating prophylaxis, contact elicitation, contact notification, like with a Hep A, meningitis, and our foodborne outbreaks. Next slide. So yeah, just a little bit of how staff are assigned cases. So as I said, we have 3 different teams, located, whether the Bronx, Manhattan. We have 5 boroughs in New York City. So we use our communicable disease database, Maven. So cases come in there continually. So every morning, the supervisors will assign any pending cases to their staff. Staff are responsible. They do their own case management and set up their schedules. So they will conduct whatever's needed. We have very specific protocols for all 75 diseases. The protocols list background on the disease, the illness, what is necessary for the investigation. And so according to these protocols, the staff would do the investigation, whether it's a patient interview, a chart review, both. Sometimes they have to contact labs and collect more information, interview providers. Prior to COVID, staff did go out in the field. They went to the hospitals to do these chart reviews. They interviewed patients in-house in hospitals and conducted home visits. Now, since COVID, and we are remote until next week, all the electronic health records are being done, through medical records remotely. And I'll talk about the challenges of that later. Next. Okay, so just to give you an idea of the volume of cases that we get. So these are our disease trends for the last 10 years. As you see, in 2019, we conducted about over 13,000 cases that year. And so we're talking about my staff, there might be 9 public health advisors. So we were getting about 250 cases for investigation per week for the 9 staff. So staff, we try to keep it below 30 per staff per day, because once they're juggling over 30 cases, it gets a little difficult. So far this year, I didn't update it. I think we had 3,600 cases investigated, and these are outside of COVID. So that the numbers for last year was everything other than COVID. Okay, next slide, please. Okay, so we also do a lot of foodborne cluster investigation and outbreak investigation, and this is an ideal way. With communicable disease, I think staff that we will pick up under this DIS funding will get a good training and experience because we have so many diseases, and outbreak investigations are pretty routine for us. So in 2019, we conducted 160 foodborne investigations. Over half of those were salmonella. So staff, my public health deputies or any DIS staff that we will be hiring and training will get a chance to do a broad range of investigations that will include contact elicitation, notification with Hep A. Hep A in 2019, we did 268 investigations, which was down. So back in 2011, we actually had 390. So with the Hep A's are, pretty complex because staff, sometimes they're really hard to reach populations. And then they have to do the contact tracing and then also coordinate the prophylaxis and working with the hospitals to ensure that contacts get the IG. Next slide, please. Okay, so now a little bit about how we work during public health emergencies like COVID. Next slide. So DOH has an ICS system. And so all staff, when they come to a program, are assigned a role. Usually our assistant commissioner will assign you. Some staff are considered COOP staff. So in an emergency, they're with the continuity of operations plan, and they work on the day-to-day work, whereas most of the other staff would be assigned to an emergency role. We have different tiers. So like tier 1 might be the staff that are the first to be pulled in an emergency, and we hold our more needed staff back unless it's a full-blown activation. We also have our employee database where we have a survey of maybe about 10 sections that staff self-report and on their skills, whether they do chart reviews, whether they have a license, if they do blood draw, and how often they do it. So we want to know, do you just have experience on it or do you do it routinely? So this data is in the employee database. So when we do have to activate, we can do a run and pull all staff in the agency that have the skills that are needed. We start out with, so usually how it goes, next slide, I think. Yeah, so usually what happens, because most of the recent activations of public health emergency outbreak investigations actually start in communicable. So it's staff in our bureau that notice something, a little clustering. We start investigating when the volume of cases to be investigated exceed our capacity. We start doing a partial activation, pulling DIS staff from other parts of disease control. So we start with our HIV staff, our STI, TB, immunizations, and pull those staff to work with us. When we need more, when we realize it's going to be a full agency activation, meaning it needs resources outside of case investigation, like community outreach, setting up some intervention like a pod for prophylaxis, then the agency gets activated. This way we're allowed to pull staff throughout the agency. So it's not just our disease control staff, but staff from, say, tobacco control, mental health, and which is great because it builds our capacity, but some staff in other divisions don't have the epi skills or the experience needed and will require much more training. Next. Okay, so this is just to give you a little feel of activations and public health emergencies we have worked on in communicable disease and have pulled DIS staff from throughout the division as well as the agency. My first activation was 20 years ago after September 11th, where we did disease surveillance after the World Trade Center. We also was at Ground Zero doing the same and doing fit testing. And then, as you know, a couple months later was anthrax. So we were doing those investigations, and we developed a lot of skills because at the pod site at the hospital where they were doing the prophylaxis, we were also doing the joint interview, bioterrorism interviews with NYPD and the FBI. We also worked on other disease surveillance, the blackout, hurricanes, in Marinum, we were investigating the outbreak in fish markets in Chinatown in New York, as well as Ebola. So Ebola, we did a lot. We did the surveillance as well as the DIS staff and staff in HIV was doing the active follow-up for 21 days, where we actually had to go in the field, knock on doors of people we didn't hear from. We have a lot of Legionella outbreaks. That's a common one. Sometimes we're able to handle it, and other times we have to pull just from disease control, like the Legionella, the big outbreak we had in the South Bronx in 2015. And then that year we had another big outbreak in the Bronx as well. Next slide. So now a little bit about COVID. So like everyone else here, I'm sure, you know, we first got wind of it through our CDC CFO in December of 2019 about the illness that was seen in China. By January, we started planning and meeting around activation, and we fully activated by February. We pulled in staff immediately from the HIV, STI, and TB, because these are staff, many of which have worked with us for 20 years on all those other outbreaks, so they know what to do and what's expected. And then it quickly escalated by March when we closed down and went remote. We had activated staff from throughout the agency. So not only were we activated as the surveillance epidemiology branch doing the cluster investigations, but the whole agency was activated. Next slide. Yeah, so, and that then became a challenge in itself, because as our priority and for our staff was doing the investigations, the surveillance investigations, staff was also being pulled because they needed some of my Chinese speaking staff to work at the quarantine hotel. They needed staff to answer to triage our call line. So staff were being pulled, the staff that worked in labs were being pulled for capacity to get the testing started up. So a lot was going on in all of the emergency response branches. So it was a juggle to get staffing needed for us to do the surveillance, investigation, contact tracing, and notification. Next slide. Okay, so what the branch, so when we're activated, all of disease control, HIV, and all staff that do surveillance are under the surveillance and epi branch. So of course, this is basic, this is what tasks that we were performing. Next slide. So yeah, I just want to take a minute to talk about some of the work we did, because it changed over time, and that was a challenge in itself. Over these past 18 months, it was constantly changing what was being asked of us from leadership, not just in DOH, but from City Hall. So in the beginning, we started with basic case investigation on the first cases we heard of, trying to get all the information, contact tracing, where they went, who they came in contact, how they traveled. And we did that for a while until it became overwhelming. When we're getting 2,000 cases a day coming in, there was no way we could interview every case. So then we moved to those hospitalized. And then that became more than what we can handle. And then we just looked at the death cases, and prioritized looking at that, chart reviewing, and that's what the DIS staff, all the staff did. Then we started, these are some of the projects and studies we did. We had a death case control study. So looking at, of all those people hospitalized with COVID, compared those who survived with those who died. New York City also noticed an increase in deaths at home. And the hypothesis was that people were fearful to go into ERs, afraid of getting COVID. So even though they were having symptoms of heart attack and strokes, they tended to stay at home and then died. So we did, so staff interviewed next of kin on our OCME cases. We also early on started calling patients diagnosed to elicit plasma donations. And we were doing, of course, and all this, the contact notification and tracing. We did start that. The mayor decided to take that from the Department of Health and give it to the hospital system, health and hospitals, but we had to then train their staff on how to do it. At the same time, we were doing SAT scan investigations. So every time we got a signal, meaning there was a cluster of positive people residing in a close proximity, during the same time, we targeted those. So the priority were these clusters. Then we did a case control study looking at people, so people in the same neighborhood who tested, say a couple days apart, the same gender, sex neighborhood, yet ones who tested positive and one who tested negative, to see what was the difference, to see if we could identify reasons some people were being infected and others weren't. We have a pediatric study. And then maybe about July, the health and hospitals realized, when the state mandated that we do these facility notifications, so it was mandated that every facility had to report to us if they had an employee, cluster of employees, if they had students, if they had people in their congregation or the house of worship, and had to call us and report it. So health and hospitals realized they could not handle that because they're not in the business. They're a provider agency and not really a surveillance and epi agency. So that was given back to our team. So we had to quickly implement facility notification. We also received 120 staff immediately from H&H. They said, here, if you take it, we'll give you the staff that we hired to do it. But that was a big challenge, suddenly getting 120 people, not DOH, that really had no background, and having to train them and supervise them to take on this new project. And our most recent study investigations we're doing is vaccine breakthrough and reinfection studies. So we're looking at people who tested positive and over 6 months later test positive again, so reinfected, a new infection. And we're also looking at people who are now testing positive after being fully vaccinated. And so that takes a lot of staff to do this. So this org chart, this is just of the facility notification piece that I spoke about, that we inherited from H&H along with 120 staff. So we had about 250 staff just assigned to this project. And so we had different teams, one that worked on all the workplaces, and we were getting a lot of big workplace clusters, 10, 20 people testing positive in the beginning, houses of worship. Then we had another group for the private events and public settings. So early on, people were still having weddings and getting together, 4th of July, and we had a lot of outbreaks. And that team also looked at the school buses. Then we had one team solely for the non-DOE, that's the Department of Ed, our public school system. So we had one team that did all the private schools, the charter schools, and then the biggest team was our Department of Ed clusters. And that was had its own challenges because they were a lot. We did not have control on City Hall was overseen because that was a high priority. This were, you know, the children and the teachers in our public school system. So challenge was setting up these organizational supervisory teams and having enough supervisors to be able to train the staff and to do QA and oversee the work that they did. Next slide. Okay, so just a little about the funding. I just wanted to say, because I really don't know much, next slide, but just to say, yeah, everyone knows that, you know, CDC put out the supplemental funding to hire, train, and support a DIS staff to support outbreak investigations, response to COVID, and any other infectious disease outbreak. New York City is getting over $8 million for this. Next slide. These are the priorities, and this is what we're planning. So in BCD, in DOH, we have a group working on this. Of course, the lead is STI. Julie is the lead on this. I do not sit on the meeting, so I'm not really up to date on the funding. I do know I put in to request a DIS staff, which would be a blessing because these staff, as you know, will be funded for 5 years to do all this work. And so, and it's not just COVID work. As I said before, we did get positions that was COVID only, but these DIS positions would be able to work on COVID as well as cross-train, which it would be a win-win because they'll be able to work on our Legionellas, our Hep A's, and all our other outbreaks. Next slide. So yeah, this is what I was going to say. So our plan in communicable disease is to hire them. They will work side by side with our public health epidemiologists, doing all the same work on both COVID and all our routine surveillance activities. Next slide. Okay, so some lessons learned. So about challenges, this was one of the hardest activations I've been through. Just COVID itself was traumatic. I mean, we've never had a pandemic like this that so personally impacted so many people. You know, even with Ebola, which was so scary at the time, you didn't see the numbers of people being infected and dying as with COVID. So in the beginning, so much was unknown. Staff were afraid for their own health and safety. They were afraid for their loved ones. They were having to be caregivers for those around them that got sick early in the beginning. So we worked in the office through March closely, 12-hour days, before we knew about masks, before these precautions were put in. I had staff that died, you know, while working in the office. So it was very hard. So just that impact alone was stressful. Then to expect people to do the work was a challenge. People didn't have the social support. They couldn't socialize. They couldn't meet with people and do the things that they would usually help them get through. Then just working remotely was a challenge. So having to supervise staff and do work remotely, train staff was difficult, especially staff for me. It's hard. People you've never met before, you don't know. Uh-oh, I'm sorry. Okay. And then staff had the whole homeschooling. So not only are they at home expected to work, they had their whole families at home. They had to care for the kids, and there were a lot of other distractions because of COVID. Next slide. Okay, so other challenges that we had with this activation was the activating of so many staff from outside disease control, staff that did not have a basic epi background. You know, we all laugh here that it was, you know, how many times we were asked and have to explain the difference between incubation period and infectious period. But we take for granted in community that other staff that we pulled in were not familiar with. Some staff never did these type of interviews before. So that was a challenge. The training, so it was training and retraining constantly. And one reason was because of the staff, new staff constantly brought on, but also because the protocols and priority changed. 1 minute, okay, we're gonna do cases. Now we're gonna do deaths. Now the distance changed, 3 feet to 6 feet, where they had masks. What is the dimensions of the room? So every time something changed, we had to train and update our materials. Like I said, the coordination of supervisory level structures. So we got a lot of staff, but then we had to identify people who were good, had good supervisory skills and could do QA of the staff as well. DOH on a whole had the technology problems. They weren't, we're talking about DOH has over 6,000 staff, and then all the additional staff that were brought on through temp agencies trying to log in remotely and access networks crashed, everything was slow. Then a lot of staff are not tech savvy. So trying to train staff to use certain programs and to use electronics. Then there's a lack of laptops. We did not have laptops for everyone. We did have cell phones, so people were using their own devices. That became an issue. And because it was remote work, then we had to access medical records electronically. We couldn't, like routinely, my staff would call the ICN and have them fax something. We couldn't do that because the staff at the hospitals were overwhelmed. So we had to set up access for the staff for our regional health information exchanges, the RIOs. We had to work with the hospitals individually and the whatever, maybe 13 to 16 city hospitals to get access directly to their medical records for staff. Another challenge was so much work. The priorities, everybody, they wanted this, they wanted that. And 1 minute we're working on that and not having enough staff. Then we would have a little lulls when there was not enough work for all the staff we pulled on. So we had to try to figure out a way to rotate people on and off. Next slide. Okay, so there's a lot we've learned. We could do better, and we're still in the process. It is not over. We are ramping up in New York City next week. The city schools are returning in person completely. Our mayor decided that all city employees should return to work full time. So next Monday, we're going to have, we're expecting an increase in cluster investigations in schools and workplaces and everything else. So what we could do better is like the recruitment. I think, I don't know how we could have done that better, but to have had more input in the staff we were able to hire, or the staff that were given to us to be able to have looked over and target and try to pinpoint staff who've done this kind of work. Set up a mechanism to rotate. So what I did is, like, when the work was when we have more staff than work each day, I said, okay, so this team, you're not going to get work for the next 2 days. They're only going to be assigned to the other team, so that staff knew, okay, these 2 days, if I need to run out and get food, if I need to do something, I can do it this day, because the next day I have to sit here and be ready to get a school cluster of 20 students. So we try to make it as easy for staff, and so that they could get some downtime. We have burnout. Staff have been doing this nonstop 18 months. So sometimes we would rotate them off. We would rotate them, activate them for 3 months at a time, maybe give them a month or 2 off, and then bring them back on. We also could have done better with training and cross-training of staff. Maybe 10 years ago, planning for the pandemic flu, I did a training of staff throughout disease control. It was like a 2-day training of this is what you might do in emergency. Here are the tools, here is this, but we haven't done that lately. And we have a lot of new staff. So we need to, and public health agencies need to train in advance staff that they will have to pull for this outbreak and create tools. Sometimes I know it's hard. You can't get a form, a questionnaire until you know what you're dealing with, but we have to have the basics, how to interview, how to chart review, and have that ready to roll out. Also, I needed more staff who could do QA, to go in, whose job was not to best, but just to go in and look at the word entered in the database and reconcile and run reports and see any discrepancies. Next slide. Again, the trainings, which I said, that is really key. We've done so many trainings and, you know, we have about 100 and we have all the slides and how they've changed, but these are very important to do, just like how to understand lab reports, trainings on the informatics, data management. And what's needed is, which I haven't discussed, health disparities and equity, cultural competency. And that's one of the things in this funding too, that CDC wants us to hire staff, diverse staff, because staff who have to, you know, who are reflective of the communities that we work with and understand the issues. We saw that a lot, especially when we were working in test sites in some communities where there were low, vaccination sites turnout and others. So we need to train staff and prepare them for all of these things listed, as well as supervisory training. Just in conclusion, we know there will be a lot of emergent infections are increasing as a public health threat, so we have to prepare. I'm really thankful for this money that CDC has and is out there for us to hire staff, to train them and cross-train them for any kind of outbreak investigations. I know in the funding, they say we should use CDC trainings. I'm not familiar with the CDC STI trainings, but I did participate in one a few months ago. STI created a training, a DIS training for supervisors, and I was one of the participants in that training. So I guess that's something when it comes out, one of the trainings that we would use. We have to create these tools, databases, forms, questionnaires, training in advance, ones that are not so specific but we can scale up, that we can build up specific to each emergency. And we have to update our technologies and ensure our staff have the technical support. It was so hard getting through, of course, to our IT department because everybody was having problems. So these are the main things that I think would help in an emergency. Next. And I just want to thank everyone and my team. If it wasn't for the great team working with, we wouldn't have been able to do what was asked of us. So I want to thank all the 400 staff that have worked with us during this past emergency. So thank you. And now I'd like to introduce our next speaker, Ryan Kramer.
Thank you for the introduction. Next slide, please. So today I'm going to be providing an overview of the rules and regulations regarding disease investigation. My talk is organized in 3 parts. First, I'm going to start with a bird's eye view of the nature of this authority. Then I'm going to talk about some of the themes that we see in these laws across jurisdictions. And then I'll end this with a focused overview of some of the special contemporary issues that we see across jurisdictions who are implementing innovative disease intervention approaches. Next slide. Next slide. The main takeaway in terms of the foundational legal authority for DIS is that this is almost exclusively an issue of state law. Not to make this into a civics lesson, but this is due to the nature of the underlying authority for federal and state laws. The federal government is one of enumerated powers. This is a fancy way of saying that its powers exist on a list. And it's a short list, primarily for purposes of regulating interstate commerce and a tax and spend. State authority is essentially everything else, as stated more artfully in the 10th Amendment of the Constitution, noted at the bottom of this slide. It's called the police power. This authority is often stated as the power to regulate for the health, safety, and morals of the state. So for purely local issues like disease investigation, this is usually the source of authority that you look to. And it should be noted that local governments derive their authority from a state's police power. It's delegated to them by the state.
Next slide, I think.
Yeah, next slide, please. So in terms of how states do this regulation, it's really one of three things. The legislature will pass a law, which is called a statute, or an administrative agency will pass a regulation. You should really look to both of these places to understand the underlying legal authority. And of course, ultimately, these laws will not address every area of practice, particularly if they were drafted in a broad, sweeping manner. So how health departments implement these policies through their own internal processes and policies should also be considered. Next slide. So what I'm proposing here is a method of assessing policies regulating DIS across states in order to both examine your own policies on factors of interest, as well as drawing comparisons across jurisdictions. This is not a technical framework. It involves only 4 factors, and not a single one is all that complicated. So the first is to look at what activities are actually regulated. Some states do this in a very broad manner, such as to prevent disease. Others are more specific, such as the investigation of cases, isolation and quarantine, and so on. Then you look to what disease is regulated. Many states will regulate this in a similarly broad manner: infectious disease, communicable disease. Other states will be a little bit more specific, such as STD, STI, or even venereal disease. And some states will be very specific. They'll actually say what must be done in the case of syphilis. Then look to whether these activities are authorized. In other words, is this a power of the health department? Or are these activities required? In other words, are they a duty of the health department? And then finally, look to what entity is actually regulated. Is it the state health department, the local health department? And sometimes it's actually both. Next slide. So we're going to walk through some laws. I am not going to make you read every bit of text on this slide. We're going to blow through a few examples to illustrate actually just how easy this is. And so I chose Alabama for our first example because their disease investigation is about as broad as it gets. So next slide. You'll see from this that they regulate disease investigation at the local level, cities and towns. Next slide. They authorize these activities. These cities and towns shall have the power. Next slide. To take broad actions to maintain the health, to prevent the introduction of contagious disease. And so, as you can see, I mean, this is just a very broad authorization. And in Alabama, this is it. This is the authority to provide disease investigation in that state. So, next slide. So this law is from Idaho, and it's another interesting example of what I would consider rather broad authority, although it exists really more at a middle ground between sort of the broadest sorts of authorities and the more specific states. It's quite a bit more focused than the Alabama laws are. So next slide. This law directs the state health department. Next slide. It requires them, will use, next slide, to do a very specific thing, to, when possible, determine all sources of infection to the extent of exposure. Next slide. And it does it in a broad fashion. It's reportable disease or condition. So for the final example, I'm using Illinois, which is a substantially more narrow authorizing type of state. And so, next slide. This law directs the state health department, next slide, to do 2 things. It requires that they adopt rules, but those rules that they must adopt authorizes them to provide for interviews and investigation of disease. Next slide. And it actually mentions STD. So it's not like the others where it's reportable diseases or communicable disease. It's actually much more narrow and focused. And then one final thing, it's kind of interesting. This law directs a state health department to do these things, but then in terms of the actual doing, it provides them some discretion in who they might have actually do it. It directs them to have authorized representatives do the interviews. So it sort of leaves the door open that, you know, perhaps like the actual doing on the ground is the state, but they could actually delegate this authority to a local health department, perhaps even federal employees, or possibly even a non-governmental actor. Next slide. So just a few observations from just across states in terms of these laws. Disease investigation of STD is virtually universally authorized across states, although substantial variety exists across jurisdictions, but the effect is the same. Legislatures vary in their level of involvement in terms of these laws. Sometimes they will regulate disease investigation in a very specific and prescriptive manner. Other times, legislatures will essentially pass these duties off to the health departments of their state to prevent communicable diseases in a manner that they see fit. And ultimately, these policies are generally not detailed enough to consider every aspect of disease investigation, leaving a lot of the programmatic day-to-day of doing this to STD prevention programs. So considering implementation via informal processes and policies is very important. Next slide. Well, I don't think that applying this framework to your jurisdiction's laws alone is necessarily that useful of an activity. So I would just like to illustrate some of the questions you may want to ask yourself about the authority within your jurisdiction. So is your authority very broad in a way that may facilitate disease investigation actions that you're not currently performing? Are you required to do a lot of things that your program may not be equipped to do? This may be a talking point for your program. And education of senior level health department staff and other decision makers of this fact may be useful. What is the source of this authority? This tells you where your lever is. If it's primarily your legislature, then that's one thing. But if it's your state health department, then your authority may be squarely within your sphere of influence. And finally, who actually holds the authority or duty for disease investigation work? In other words, who's actually regulated? This answer may sometimes be surprising, as illustrated by Illinois. Next slide. Now I'd like to discuss just a few special issues and disease investigation that seem to be coming up as programs think about how GIS can be used in innovative ways to address contemporary challenges. I address these separately from the first part of the talk because these non-traditional topics may not fit obviously within a state's primary legal authority for disease investigation that we just discussed. Next slide. The first issue is confidentiality, particularly across digital platforms. Ultimately, states will generally have laws that regulate the use and confidentiality of public health data held by a state. This applies to the entire program, and I would expect that programs generally understand these requirements. It's important to note, though, that this is probably not HIPAA. There's a tendency to think that HIPAA is sort of the primary legal authority for the regulation of health-related data, but that's not usually true of non-clinical public health data. I also want to just raise that some states have confidentiality protections in place for disease investigation specifically. The following example is an Illinois law, and it states that all information gathered in the course of contact investigation pursuant to this section shall be considered confidential. And it's also exempt from its states from the Illinois Freedom of Information Act. So as you can see, it's not especially technical, and frankly, this is probably duplicative with the state's broader law that regulates confidentiality of public health data, but it's just something to remain aware of. Next slide. So programs are using social media platforms as part of investigations and internet partner services, particularly where a person does not know the identity of their sexual partner who they may have met through these platforms. Furthermore, organizations such as Building Healthy Online Communities have developed a lot of resources around this, and they've engaged these platforms. So this is totally possible and it's happening. Which is to say, nothing I'm about to say should be interpreted to mean that this cannot be done, but it should be considered a suggestion that you act deliberately in this space. And that's because these platforms involve a lot of rules, as stated in their terms of service, And ultimately, you don't have a right to be on the platform. It's a privilege, so you need to operate within the rules. Next slide. So I took a deep dive into Grindr's terms of service, a gay dating social media platform, because it has been subject to a lot of discussion about internet partner services. And again, building healthy online communities has engaged and partnered with Grindr, so this is totally possible. But although just through this exercise, I hope to illustrate some of the issues that you might encounter. Social media platforms often include similar provisions in their terms of service, and the social media landscape rapidly evolves as platforms come and go. So like the laws discussed previously, we're not going to read all the way through this, but I do want to pull out just a few interesting pieces. Next slide. So first, there's no stalking on this platform, which I think we generally understand to be pursuing an individual with malicious means. Although a platform could also interpret this to mean pursuing an individual for purposes outside the scope of the intended purpose of the platform. And ultimately, they decide what these terms mean. Your use is a privilege. So there's also no collection of personal information, which is sort of central to an investigation. Next slide. Grindr prohibits non-private use, and they emphasize that when you're using Grindr, you are playing by their rules, that's stated in the terms of service. Slide. They prohibit the use of their platform for surveys or studies, which may have implications for how your program uses any information uncovered through such an investigation. Next slide. And ultimately, they prohibit impersonation. So it's probably wise that any agent of the health department represent themselves as such throughout the entire process. So the takeaway here is that it's very important that you read and understand the terms of service as you develop an approach to using these platforms for disease investigation. Next slide. Some jurisdictions are examining how they can augment both their clinical services as well as their DIS work by providing field testing and treatment performed by DIS. You're going to hear a lot about this in later sessions during this meeting. Generally speaking, testing and treatment are actions that are reserved for healthcare providers as defined by their state scope of practice laws. However, some jurisdictions have forms of standing orders or standing delegation orders by which a physician can delegate limited portions of their scope of practice to non-healthcare providers. Next slide. So one such jurisdiction is Texas, and in their law regarding standing delegation orders, they actually authorize physicians to delegate the ordering of STD tests and the administration of antibiotics for STDs. So it may be worth understanding the legal landscape for scope of practice and standing orders within your jurisdiction. Next slide. So in conclusion, the legal authority for STD disease investigation is virtually universal, although significant variation exists across states. Understand this authority and think critically about how it relates to your programmatic activities. Finally, for more innovative DIS functions, you may need to consider policy issues outside the scope of your state's basic disease investigation authority. Next slide. And just one final note, DSTDP has collected relevant policies across states and has categorized them per the framework that I discussed earlier in this presentation in order to support state and local initiatives to better understand your disease investigation authority. We hope to publish this analysis in the special issue associated with this meeting. And of course, we are always available for technical assistance, including on policy issues. Thank you. Now I'd like to introduce our next speaker, Raul Ramagera, who will be discussing funding and accountability.
Thank you, Ryan. And good afternoon, everyone on the East Coast, and good morning for the rest of the country. Today, I will be talking briefly about funding and will mostly focus on accountability. When Sevgi asked me to talk about accountability, my immediate reaction was that there was not much to say, since accountability was mostly about tracking funds, legislative compliance, and providing administrative oversight. And we typically do this by requiring performance indicators, and that is going to be covered in another talk during this meeting. As I started researching the topic, I found a few articles like this one, demanding accountability from governmental agencies. In this particular one, the radio host questioned CDC's development of a COVID test. And I quote, "The CDC went the bureaucratic route. They chose to invent a brand new test kit in the middle of the crisis and forbid anyone else from playing in the game. We lost time that we didn't have in the middle of the crisis. To me, this is exactly what happens in a bureaucracy. Next. Accountability is usually discussed upfront by philanthropic and corporate donors before they issue a grant. In 2007, a joint working group of the Council on Foundations and the European Foundation Center agreed that the fundamental question every international donor should ask of itself is, to whom is my organization responsible as it makes grants or develop projects across borders? And how can funders ensure that the philanthropy is carried out in an accountable and responsible manner? So what do they mean by accountable? Next. The joint working group also developed the following principles of accountability for philanthropic organizations. These are integrity, which means to be truthful to the vision, mission, values, and core principles of the organization. Understanding and researching the political, economic, social, cultural, and technological context. Respecting cultural differences and human diversity. Be responsive to the needs and realities of grantees. Be fair, which means that the project demands need to be proportionate to the level, purpose, and nature of the support provided. And to expand cooperation and collaboration among other donors and with a variety of actors, including NGOs, businesses, governments, and multilateral organizations. And finally, to assess effectiveness and demonstrate how the program contributes to the achievement of the organization's mission and the advancement of the public good. Next. So we have to ask ourselves, why do we need accountability in public programs? And what should it look like? In general, accountability is associated with a responsible government. It is characteristic of democratic forms of government. It has been prioritized by the US government for the past 30 years. It is included as a function of leadership and governance. It is central to improving equitable access to public services. It should document what the public is getting for their taxes and how well those funds are spent. And it is essential for the integrity of the overall public system. Next. Let's now go over some definitions. Accountability can be defined differently by different disciplines and by social, cultural, or institutional conditions. However, we can agree that accountability derives from being accountable, which is a quality or state of being where one accepts or is obliged to accept responsibility for one's actions or inactions towards another. In general, accountability is taking responsibility for a particular action or goal, and it assumes a relationship between two actors. However, public accountability also requires that the public sector demonstrate competence, reliability, and honesty, and allow the public to judge its trustworthiness in using public resources. But then we have to ask ourselves, are civil servants accountable for program delivery or for outcomes? Next. This slide shows the interconnectedness of the public accountability system and the public management system. The public accountability system supports public trust and confidence, and this in turn supports the public management system. Public trust and confidence in the public management system increases as public value is created and demonstrated. And public value refers to the value created by government through services, laws, regulations, and other actions. Next. In 2001, Robert Benn from Duke University suggested that there are 4 types of accountability. Accountability for finances, for fairness, for the use of power, and for performance. We will look at examples of each other. According to Benn, the US government has traditionally created detailed formal procedures to ensure that its agencies and employees are accountable for finances and fairness. And in the interest of improving performance as required by law, we are now asking frontline workers to be more responsive. We are urging middle managers to be innovative, and we're exhorting public executives to be entrepreneurial. But measuring performance can be difficult and presents significant challenges, as we will revisit later. Next. Accountability for finances is the type of accountability most used by governmental agencies. One example is the HHS tracking accountability in government grants systems, or tags. As we can see under the logo, it says tracking spending and increasing accountability. I think it's very small, so you cannot see it from here, but it tracks all grants, cooperative agreements, and contracts issued by all parts of HHS. It also includes copies of the abstracts applications received by HHS, by grantee and contractor. There are plans to include performance measures, but that information is not widely available yet. Next. Then we can move and look at accountability for fairness. Some accountability experts have posed that healthcare institutions engaged in priority setting have a claim to fairness and equity, but only if they satisfy 4 conditions. The rationale for priority setting must be publicly available. The rationale must be considered relevant by fair-minded people. There also must be an avenue for appealing decisions and to appeal the rationale. And finally, there must be some means, either voluntary or regulatory, of ensuring that the first 3 conditions are met. Shown here on the right side is a list of the elements of fairness that were identified by decision makers across several health systems and levels of priority. Levels of priority setting. Next. Another important question we should ask ourselves is, why do we and grantees worry about accountability in government? And we can probably agree that it is because we fear that public officials, including elected officials, appointed executives, or civil servants, will abuse power. And as we have witnessed recently, many public officials do have a lot of power. Hence, next. The next type is the accountability for the use of power. The accountability of power aims to reduce the abuse of power by government employees, which is crucial for democratic societies. Next. Next, we have the accountability for performance, which has evolved over the years in the US government. In 1947, the sociologist Max Weber suggested that a responsible bureaucrat needed to document his practice, but guard the practice against political interference. Back then, archives were closed and accountability was centered around private room discussions. By the end of the 20th century, accountability was associated with system level and centered on access to data to document public services. Over the past 30 years, various US government administrations have focused on initiatives to improve accountability, and these include the 1993 Government Performance and Results Act, or GPRA, which required federal agencies to set goals, measures, report progress, and conduct and use findings from evaluations to improve programs. In 2004, a program assessment rating tool was released by the government to help programs determine the causes for strong or weak performance and to take action and remedy deficiencies and achieve better results. The 2010 GPRA Modernization Act built upon GPRA requirements and added a few additional requirements, including the development of a central website to provide a comprehensive picture of government performance and to align planning processes with election cycles, so that would allow new administration to set up their own priorities. In 2018, the Foundations for Evidence-Based Policymaking Act emphasized collaboration and coordination to advance data and evidence building functions. Next. And most recently, in June 2021, OMB issued a memo advising the heads of executive departments and agencies to use evidence whenever possible to further both mission and operations, and to commit to build evidence where it is lacking. The current OMB focuses on outcomes. which is a state where agencies use all available evidence to improve programs and ultimately serve the American people more effectively. As we can see, accountability for performance has evolved over the years from requiring performance data to using this data to now develop evidence. Next. However, Mark Friedman, the director of the Fiscal Policy Studies Institute, argues that achieving population-level well-being is complicated because it depends on too many different people, groups, and industries. Therefore, he claims that accountability for population-level results cannot be assigned to any one individual, organization, or level of government. The whole community, the public and private sectors, must share responsibility for population-level results. There are many governmental agencies charged with holding public programs accountable, including this one, the US Government Accountability Office, or GAO, which provides Congress, the heads of executive agencies, and the public with timely, fact-based, non-partisan information that can be used to improve government and save taxpayer dollars. Next. Then there is the HHS Office of the Inspector General, which is responsible for providing oversight to prevent the inefficient and unlawful operations within the agency by identifying, auditing, and investigating fraud, waste, abuse, embezzlement, and mismanagement of any kind within the executive department. Here is the cover of their 2020 annual report on challenges facing HHS. And the first section of this report is on safeguarding public health. Next. On the non-governmental side, we have the Public Health Accreditation Board, which has developed standards and measures for state and local health departments. Domain number 2 focuses on the investigation of suspected or identified health problems, which covers the functions of DIS. This includes identifying emerging health problems, monitoring of disease, availability of public health laboratories, containment and mitigation of outbreaks, coordinated response to emergency situations, and communication. Next. Now let's bring all this information back to accountability of the DIS work and functions. And this slide is the only time I'll bring up funding. With permission from our colleagues, Shante Wright and Brittany Johnson, I want to share with you preliminary data that were collected in phone calls between our staff and STD PEACH recipients. As you can see here, the majority of the jurisdictions funded through STD PEACH are using a combination of federal, state, and local funding to hire DIS. They also learned that about 37% of the jurisdictions reported that their DIS can be employed by state or local jurisdictions. Next. Accountability becomes particularly complex in federal systems where 2 or more levels of government enter into collaborative agreements, and when these services support multiple types of programs, as is the case of DIS, where they may support STD, HIV, viral hepatitis, and outbreak investigation for other infectious diseases, such as Zika, Ebola, and now COVID-19. Challenges in accountability of STD prevention work, including DIS functions, will remain until we agree on a definition of what accountability precisely means for STD programs, and more specifically, for DIS work. Then we have to answer the following questions. Who is accountable and to whom? The federal, the state, local, or the community? What are the expectations for DIS services? Is it individual or population outcomes? Do we focus on improving program performance, including DIS productivity or program impact? And how do we measure the desired outcome? What are the targets? Who sets these targets? And how should we document and report these measures and targets? Or what would be the consequences of not meeting these targets? Next. Finally, once we agree on a definition of what accountability means for DIS work, we can probably agree on the tools and metrics that we need to hold all of us accountable. During the course of this meeting, you will hear other presentations that will guide the discussion, including a cost-benefit and cost-effectiveness analysis, the use of quantitative data to allocate DIS resources, the power of equity and partnerships in DIS work, and performance metrics and outcome assessment. Once we have answered all questions, We can then consider updating the program operations guidelines for STD prevention and possibly this guide to program evaluation to include a section on accountability. Thank you. Next. And next. Our next presenter is Dr. Thomas Gift.
Good morning or good afternoon, as the case may be. I'd like to spend just a few minutes talking with you about the principles of cost and cost effectiveness analysis as applied to DIS services. Next slide, please. So first, some basics. When you're trying to assess the cost effectiveness of an intervention, you can start with either a given set of resources and you want to maximize the health gains that you can realize with those resources, or you can have a given health objective and you want to achieve it as cheaply as possible. Cost effectiveness analysis simply quantifies the trade-offs between the costs and benefits of the health intervention. Typically, we're looking at two different interventions that are alternatives, and therefore we calculate the difference in cost over the difference in benefits achieved between the two, and that gives us a cost effectiveness ratio. Next slide, please. So for cost measurement, when economists talk about cost, they're talking about opportunity cost. This might be the financial cost. It might be the number of dollars that trades hands for the good or service, but not necessarily. And one of the ways in which this can impact assessments of DIS interventions is considering volunteer time or donated resources. If a health fair donates a booth to the health department and DIS staff it, the financial cost is zero, but there is still a cost. There's value attached to that resource, and it might be better used for some other purpose, and therefore its cost should be accounted for. Another factor that matters is the cost perspective. When economists talk about the perspective, we're just assessing whose costs should be included. A payer perspective would be something like an individual health plan or the health department. The healthcare system is a broader perspective, and it typically includes all direct medical costs incurred. And analyses that take a healthcare system or broader perspective typically will have a longer time horizon. So some of the more distal outcomes associated with, say, an incident chlamydial infection, such as treatment for tubal factor infertility, can become relevant here. And then the societal perspective evaluates everybody's costs, even those of patients. Important considerations for DIS, apportionment of staff time. As you've heard so far today, DIS do an incredibly wide range of different activities. It varies by health department, but apportioning their time among those activities is a real challenge. And then time costs or travel costs and vehicle mileage are obvious. And then patient time costs are relevant as well. For example, if you're looking at something like field testing versus asking all partners to go to the clinic for testing, that's going to have implications for the patients. Next slide, please. DIS outcomes that matter. So there are process things to look at and then final outcome measures. I'm not going to spend a lot of time on this because it's going to be covered in detail tomorrow. But a good example is a study done by Johnson and colleagues in 2017 looking at partner services in New York State for STI and HIV. Some of the process measures, sort of the assessment of how the work was getting done, the number of index cases assigned, the number of patients interviewed, the number of partners notified of exposure. That's an assessment of how well the intervention is functioning. And then the things that we typically look at for cost effectiveness analyses are things like the number of infected partners who are treated, the number of partners who are tested and newly diagnosed with HIV. And then you could add to this partners linked to PrEP or previously diagnosed HIV and patients re-engaged in care. Those are the final measures that we typically try to look at for cost effectiveness analysis because those have costs associated with them. Next slide, please. So as noted, DIS do an incredible lot. They do partner services for HIV and STI, which can include just contact tracing as well as EPT and field-delivered testing and treatment. But then they do broader health services as well, such as enroll partners that they're locating into health insurance, connecting them to primary care providers, referrals to mental and sexual health services, or enhanced surveillance activities. We did a survey of local health departments and state health departments in 2018, and all of these different activities were performed by some level of health departments. And it's written up in the reference at the bottom of the slide. And then they do outbreak responses you've heard this morning. SARS-CoV-1 is an example. Foodborne outbreaks, as you've heard, some large health departments may have completely different divisions that handle that. And then H1N1 in 2009, as well as COVID-19. Next slide, please. So when we look at some of these indirect and long-term outcomes, it can be difficult to measure the full health benefit of these services. Long-term health outcomes associated with connecting a patient to care, enrollment, and health insurance, there is value associated with that. They can access preventive services, and it may deliver health gains to them that go way beyond the STI/HIV field. Then there are transmission dynamic aspects. Treating a case of a disease in a partner prevents transmission from that partner to further people, and it can have a level on it can have an impact on the level of community prevalence. There's value in surveillance and mapping sexual networks. If DIS get to know their local jurisdiction and cases of LGV start to crop up, they may have a feel for where the transmission is happening, and that can enable more efficient targeting of resources. So there's value to that as well. And then critical public health infrastructure, as previously noted for outbreak response, having that ready force available to surge out into the community if needed. Now, these types of things can't be directly measured, and they're not typically going to be collected as part of program evaluation. Possible solutions to this are to use statistical modeling to estimate the population level effects of the policies. There was one example done of this also in New York State, looking at the impact of DIS coverage on STI rates by Dew and colleagues. And then the impact of federal STD funding on reported chlamydia gonorrhea rates. This was a very high-level analysis done at the state level nationwide over a long period of time, but it found that there was an association. Next slide, please. So quantifying DIS outcomes for cost-effectiveness analyses. Given that cost-effectiveness analyses are used to identify optimal interventions, how do you deal with these three scenarios? How about optimizing DIS workflow between two different activities? That's pretty straightforward. Optimal DIS staffing allocation versus alternative STD program activities. Maybe trying to decide whether we should hire more DIS or open another clinic. That's a pretty broad question. Expanding telemedicine services. Maybe sending some DIS to telemedicine to perform certain functions. How about optimal DIS allocation versus alternative public health activities? The county health department might be interested in looking at hiring DIS or some method of expanding child vaccination services or starting a smoking cessation awareness campaign. These are very broad and in some senses dissimilar interventions, but at some level there are decision makers that wrestle with these challenges to try to determine where to put resources. Now, the second panel on cost effectiveness recommended a fairly broad approach to assessing outcomes and impacts of health interventions. This was not something that was focused on DIS. It was rather looking at all health interventions and issuing some general guidance for how to assess them. So yes, count the health insurance signups if you can. Next slide. The way that this is typically done is to use a common outcome measure, such as a health utility measure. These are generally generated based on population level preferences for health or possibly through expert panels. And the ones that you have likely heard are quality adjusted life years, where 1 is perfect health, 0 is death, or disability adjusted life year, where 0 equals no disability and thus perfect health, and 1 equals death. And just a quick quantitative example here of how this gets calculated in practice. If you have inpatient ectopic pregnancy and you spend 3 days with only 23% of optimal health, and then 28 days recovering at about 2/3 of optimal health, you see that that ends up being just 0.0324 quality loss. And you might be thinking that's pretty small, it doesn't look like much. And one of the factors associated with these short-term acute conditions that resolve is that they don't have a big impact in terms of quality adjusted life years, whereas a chronic condition that goes on for a long time has a bigger quality impact. Next slide, please. And then another approach to this is to just do cost-benefit analysis where you express everything in terms of dollars. A benefit-cost ratio over 1 means that the program delivers more benefits than costs. And these ratios can be used to select optimal interventions. You use a common metric for everything. And you might be asking, how do you value non-monetary outcomes in such a situation? And it's typically some form of contingent valuation, willingness to pay, where you try to determine how much people are willing to pay to avoid or achieve a given health outcome. All this being said, while these are theoretically attractive because they make comparisons direct and easy, you don't find a lot of them in the literature. Next slide, please. So here's an example of a broad-based attempt to assess all of the A and B rated U.S. Preventive Services Task Force recommendations, as well as the ACIP recommended vaccines. They wanted to assess all of them. Next slide, please. So they divided these into 2 assessment criteria: clinically preventable burden, that's CBP, and then cost effectiveness, CE. You can go to the next slide, please. I'll blow this up a little bit for you. I don't want to get too bogged down on this slide, but you can see that they assign numbers. 5 is good, 1 is bad, and so the most cost-effective and largest health impact service was childhood immunization series. And then down you see that the chlamydia and gonorrhea routine screening of sexually active young women and older women at risk. It's not at the top, but it's definitely not at the bottom either. Next slide, please. So these are very broad and they're very high level, and they enable you from a 10,000-foot view to make decisions about prioritizing services. But there are limitations to this approach. These analyses are very high level and they're not going to be applicable to all settings. These analyses do allow for ranking and prioritization, but societal or healthcare system perspectives may not match the needs of a given jurisdiction. And then qualities are not well defined for some outcomes. Next slide, please. This is just a listing of a few studies that have tried to quantify DIS impact or assess their cost or cost effectiveness. Next slide, please. And so I can wrap this up. Basically, more data are needed to fully assess DIS cost effectiveness. In order to look at particularly some of these innovative ways that we're thinking about stretching DIS to push them into new areas and do new things, some of the outcome and cost data needed to do a cost effectiveness assessment of that are going to require focused effort to collect, and it will go beyond what the program will routinely be collecting. Common health measures are useful for cost effectiveness analyses that achieve different health outcomes. Broad analyses that capture all health outcomes are optimal, but that being said, narrower analyses can be useful. The example I mentioned a moment ago, do you do field testing or do you ask the patients to come to the clinic for testing? That's a very narrow question, but an analysis focused on just that, ignoring all of the other things DIS do, can deliver some value. And regardless of it all, cost effectiveness analysis is a tool that can help optimize DIS activities. And that is all I have. Next slide, please. And next slide, we can go next to David Johnson. Thank you.
Good day, everyone. Appreciate your patience. And so let me go right into this. So here, this comes from, my slide comes from the Crisis and Emergency Risk Communication Model that the Centers for Disease Control established back in 2002. So what I'm going to do is just actually, there's 6 components to this model. And for this presentation, I'm just going to cover the first 3. Next slide, please. As what's been covered already by other presenters, the DIS, and for this presentation, I'll just won't go back and forth between DIS and PHA. I'll just stick with DIS. As they've alluded to, a long history of being first in providing information. And it really in the last 30 years, as was shared by Matt Golden and others, that responsibility has expanded. And I've underlined counseling and community engagement because we have used those terms loosely, and we need to be very careful about saying counseling and community engagement to communities, because how they may receive that is dramatically different on what our interpretation is of that. And so this is why I've underlined counseling and community engagement, because we use those terms fairly loosely. Next slide, please. As you can see here and what's been shared, the original focus for syphilis elimination was, for DIS was around syphilis investigation. And here the fascinating and interesting thing is, and Matt shared some of this, is just the language that was used early on in this, as far as suspects, associates, case allowed, Peter meter, chalk talks. And this is a way of identifying strengths, weaknesses, opportunities, and threats in a syphilis investigation. And this was a language that no one outside of the DIS world understood or spoke. And even to the point where what we call dispositioning field records, 1, 2s, and 3s. All interesting language, again, that was not understood outside of the DIS world. The interesting thing is, though, success was measured, success and failure was measured among DIS on how well you did this. And depending on how well you did this, you could create a legend for yourself in the annals of DIS lore. But the problem with lore is that it tends oftentimes to blind us to both the past and the present. Because, and this is the interesting thing, nostalgia is what you want to hear, but history is what you need to know. Next slide, please. And with that, just want to quote quickly from Hassan Kwame Jeffries, a history professor at Ohio State University, from his 2020 TED Talk, Why We Must Confront the Painful Parts of US History. And I quote, "We love stories about the past that make us feel comfortable about the present, but we can't keep doing this." And as you see here on the slide, if you look at and take this perspective from Black, Brown, and LGBTQIA communities, they don't have the same splendor and good purpose through the eyes of DIS. And there's a myriad of reasons, but it's stated nicely here for the second bullet. This comes from Peter Hepburn, an assistant professor at Rutgers University. And it basically hits the point that the intervention was never designed, excuse me, by the populations that we are intending to serve, and they were never consulted about it. Next slide, please. And so happy that Ryan alluded to the police state and a police approach to some of the public health investigation. And this is how the community, when you take it from the community perspective of how they oftentimes perceive this. And I think what's been summed up nicely here from Rob Wallace, an evolutionary biologist, and he states, public health as an individual intervention, like we treat police investigations. Each investigation is an individual event without ever examining the whole. And so using terms like suspect, associate, and investigation, and again, we're looking at these things as investigations, police investigations, and at the same time, we're looking at individual level interventions. And this is not uncommon and unknown, because even with the George Floyd and everything else that we've seen, it's come to the realization that even with police work, it cannot be done as an individual issue when you've got macro level problems in the community. And a book by Professor Rosa Brooks, Tangled Up in Blue, Policing the American City, aptly describes on how we need to expand and look at macro level issues that are really driving a lot of these problems. And the approach that we have used, in my opinion, I should have added that I was a DIS years ago, started out in 1983. And so I've got some level of understanding about this. This approach of taking a police investigation oftentimes traumatizes the community and individuals within the community. And we end up re-traumatizing people that have so many other issues. And not only do we traumatize the people in these communities, but I think oftentimes we ourselves in public health are traumatized because we are struggling with how best to adequately address health disparities and achieve health equity. Next slide, please. And I think one of the things that we have to come to grips with is that we have to acknowledge that what we know ain't so. And this is taken from Ezra Klein in one of the New York Times op-ed columnists. Because one of the greatest sources of our suffering are lies we tell ourselves. And one of the things that we've got to do is we've got to stop pretending that people who live in underserved and marginalized communities are the problem. We've got to develop interventions and policies that confront those issues that either harm, hinder, or impact underserved and marginalized communities from thriving. And we've got to, again, move away from these individual level interventions and look at more macro level issues. And so what ain't so? Next slide, please. What ain't so is the training that we provide, DIS. Because oftentimes what the training is very technical. And as you can see here, visual case analysis is an example. And I know some of my previous speakers talked about some of the training. And again, very technical level, and the primary focus being around understanding and really being cognizant of a number of these technical terms. And next slide, please. Even as we're forward thinking here, as you can look at the 18 modules that are listed here going forward for 2021. Again, very, very technical. And the thing that resonates with me both from the previous slide and this current slide is, did we ever engage the community? Next slide, please. And you can see here what's missing are 4 things that I've highlighted here. Both the individual and those individuals that live in the communities we're trying to serve, soft skills that I will talk about in a little bit here, that being human interaction and community engagement, leadership skills, which I will highlight, and then the 4th being ethics. Next slide, please. As you can see here, where we need to better focus and highlight our training is moving away from some of the more technical kind of things. And really what we need to do is have non-clinical expertise that fosters trusting relationships within communities. And this comes from work by Michaela and others in their work with the violence and intervention specialist in Baltimore. And we really need to be able to have our training focus on those social issues that impact the lived experience of people marginalized because of place, poverty, race, ethnicity, gender, sexual orientation, and disability. These are definitely social justice issues and human rights issues. And I want to highlight and really emphasize not equity issues, but human rights, because oftentimes we don't end up seeing people in these marginalized and underserved communities as humans. And so it requires a different approach as how we're thinking about and a different type of leadership. And so this gets into the next slide on where we might be thinking about the need for soft skills. Now, when we look at the term soft skills, and just a little quick background on that, this was a term that came from the US military back in the late 60s. And they really looked at this between 68 and 1972. And think about just the history of that and what was happening during that time. You had the Vietnam War that was coming to an end. And there were a number of issues and challenges in Vietnam that resulted in how soldiers were trained, and you had the My Lai massacre. You had officers getting fragged, that is harm done on them because of their poor leadership skills. And so what the Army did, they took it upon themselves to really take a hard look at this. And so they ended up having a 2-day conference, December 12th through the 13th in 1972 in Fort Bliss, Texas. And the title of the conference was the Continental Army Command Soft Skills Training Conference. And really what it came down to is, and they recognized that many soft skills result in a product. And they further broke it down that really when you focus on soft skills, it is easier to derive standards. And I'll just give you a little quick background on just the impact. And as you can see here and highlight the important things of soft skills and even how they have more impact than some of the academic and technical skills. Just want to quickly, Fannie Lou Hamer, a political activist out of Mississippi, who with a 6th grade education really rocked the world in her big movement for pushing for voting rights, improving health outcomes for those individuals, not only in Mississippi, but throughout the nation. And she also, in working very closely with others who were not as educated, Ida Mae Holland, who later ended up changing her name to Andessa Ida Mae Holland, ended up eventually getting her PhD from the University of Minnesota, worked closely with Fannie Lou Hamer. Ida Mae Holland stumbled into this work, and it was an unfortunate circumstance because if you think about it, in 1960, in the 60s, where Ida Mae Holland was with her mother, where her mother worked for an individual, and this man ended up raping Ida Mae Holland at the age of 12. Obviously, traumatic experience for her, ended up prostituting at 14, and then stumbled into this work with Fannie Lou Hamer through the Student Nonviolent Coordinating Committee. Both of these women, again, coming from humble circumstances and traumatic circumstances, but again, because of soft skills and being able to communicate, being able to listen, being very interpersonal, were able to make great advancements around Voting Rights Acts and the issue of advancing healthcare and other needs for underserved and marginalized communities. Next slide, please. And as you can see here, that it was interesting, and again, as I highlight, the military knew that the soft skills were just not for the soldiers. They were looking for leadership as well, that they needed to address this as well. And so if you don't have these 4 elements here in leadership, it really is not going to help if you focus soft skills just on line staff. And so they were very critical and instrumental of looking at these core leadership skills that were needed. Before we move on, I did not put in intentionally a slide around ethics, because one of the things that I think that we have not done an adequate job of is really teaching around ethics, because one of the things that I can recall is some unethical things that happened where we had, just as an example, I will quickly highlight, a young woman, adolescent, who was diagnosed with syphilis. In the interview, the individual who was interviewing her shared with her at the time that their partner refused to engage in oral sex with them. Not appropriate and wasn't a place to even begin having that discussion. Another example, a DIS non-clinical chose to try to examine a young woman to see if that individual had lesions on her genital in a non-clinical setting. And even I will admit to my own bonehead move, when I was early starting in my career as a DIS, we had an outbreak of penicillin-resistant Neisseria gonorrhea. The clinic was going to be closing shortly, and so had I not got the individual into the clinic, that meant taking that person to the public hospital for a long hours wait. So in rushing there, I got a police escort, picked this individual up in a predominantly Black neighborhood, and then police escort back to the health department. Not thinking that the precarious position I put this young man in on having to go back and tell why there was a police escort in picking this person up. And so it's these kinds of unethical things that we need to be addressing and training people on. And I think it speaks to some of the points that Matthew was making earlier about why we're not as successful, because whether it's 1 or 100, they are all too many. And addressing issues like this is probably why we're not, having as much success as we might be able to, because of some of these unethical practices. Because again, there are others that I could share with you, but I just wanted to quickly highlight those 3. Next slide, please. And so here, be right. And I added, and after more thought, I probably should have changed this to be relevant. But here, just very quickly, the important thing about being right is that what we have to admit is there are things that we don't know. And really had an opportunity, and would encourage you, if you get the chance, to read Adam Grant's book, Think Again, The Power of Knowing What You Don't Know. And what he stresses is what we have to do, we have to learn, unlearn, and then relearn. because what we have to be able to understand, there are things that we were taught, and that as time goes on, we have new information, then we need to unlearn those things that we were taught, that we find out now that are no longer valid. And then we need to relearn. And if we follow that methodology, even as we're working with communities, what we need to do is we need to have a little bit of luck on our side to do this. And when I say luck, what I mean is learning under correct knowledge. This comes from Yusef Salaam. He was one of the exonerated 5 in his book, Better Not Bitter. And he talks about the importance of learning under correct knowledge. And this is where we engage and involve the community as we're developing our interventions. And we tap into their expertise, we tap into their knowledge and their insight, which would give us a lot more relevance as to what may work best in their community. Next slide, please. And so on these next 2 slides, you can see that there are a number of things that we do know here. And this comes from the Hidden Epidemic from the Institute of Medicine report. And again, a number of things that we do know. Next slide, please. Okay, so the challenge that we face is what makes this, why are we battling with this whole thing around relevancy? And really the issue is there is this internal division that we've got, not only within our division of STD, but also within ourselves. And here, even as we struggle with the name of the division of STD, sexually transmitted disease, we're even not relevant, because oftentimes I get hit with folks from the community. Why do you still call yourselves the Center for the Division of Sexually Transmitted Disease as opposed to infection? And again, even the community knows and sees where the relevance is and where we're a little bit outdated and out of step here. And really what I think is this internal division, what it boils down is to fear. As an organization, we are risk averse. And so oftentimes what we do is we will follow process repeatedly to ensure that all I's are dotted and T's are crossed before we even release any information. And oftentimes in following this process, the information, once it's released, is outdated and no longer relevant. And so next slide, please. So we need to be able to confront these fears if we're to establish credibility within the community writ large. And I know that one way that we can eliminate fear is that we need to be able to have a goal. And really, I kind of just was kind of playing with some words here. And one goal that we could possibly look at is to establish a value-based and increasingly community-integrated approach for addressing endemic infections and outbreaks. And really, I'd like to think that I came up with it on my own, but I took from a campaign slogan by Charles Booker, who ran for the US Senate in 2020 in Kentucky. And his from the hood to the holler. And although he was not successful, one of the things that he did do is that he created an organization in Kentucky, Hood to the Hollers. And the goal is similar to the goal that I outlined here, building broad coalitions, breaking down barriers of race and class, and fueling a people-centered movement to build power and transform our future. And so that is helpful, having this goal. But as I further looked at the challenge is it does not eliminate fear. And unfortunately, too many of our policies and rules and regulations are based in fear. Next slide, please. And here, as you can see, when I'm talking about fear, what I mean is fear being false evidence appearing to be real. And again, this comes from Yusef Salaam's book, Better Not Bitter. Fear, again, false evidence appearing to be real. As you can see here, there are a list of sexist and racist tropes and pathologies that date back to the 18th century that we have used. And this is really the foundation of what DIS was propped up upon. And as you can see here, this is just not me talking. There's a list of a long list of work that's been done. Just want to highlight a few of those bodies of work. Dr. Joy DeGruy in her 2005 book, Post-Traumatic Slave Syndrome, American Legacy of Enduring and Injury and Healing. Dr. Marvin D. Jones, an attorney, also wrote a book in 2005, Race, Sex, and Suspicion, The Myth of the Black Male. Sabrina Spring's book, Fearing the Black Body. This came out in 2020, The Racial Origins of Fat Phobia. Dr. Thomas Foster in 2019, a history professor at Howard University, Rethinking Rufus, Sexual Violations of Enslaved Men. Paola Ramos in her 2020 book, Finding Latinx in Search of the Voices Redefining Latino Identity. And then finally, Athena Butler's book that came out this year, White Evangelical Racism, The Politics of Morality in America, and which really speaks to policies that are still driven by this kind of morality that we have in this country. And again, I want to just kind of quote here from Asami Kwame Jeffries from his TED Talk. And what he writes is, or what he states is, my fear is that if we don't remember the past, we will continue it. We will continue to do the things that created inequality and injustice in the first place. And I know that as he goes on, the notion was that once we elected our first and only Black president in this country, we stopped doing the things that we thought we had stopped doing, the things that have created inequality in the first place. The harsh reality is that we haven't. And the other thing that we have to come to grips with is these inequalities are just not hurting Black and brown folks. It's hurting poor white people as well. And a fascinating book by Dr. Jonathan Mitchell in 2019, Dying of Whiteness, How the Politics of Racial Resentment is Really Killing Americans in the Heartland. And so what we've got to do is study hard history to really get an understanding of the foundation of a number of our approaches to public health, and especially public health for those Black and brown communities. And so here the take-home message, at least for me, is that what we've got to do is practice cognitive empathy. And this is placing yourself in someone else's situation to gain a better understanding of their lived experience as we engage people from diverse class, race, ethnicity, gender, sexual orientation, and disability. And only by doing this is where we're going to create an opportunity for us to not only build trust, but to help in developing beneficial and impactful public health interventions and policies. And so you might ask, so how do we do this? And so one of the things that we need to do is we practice Sankofa. And Sankofa is a word from Ghana, and it means go back for that which we have forgotten. Next slide. And what we have forgotten is, and as I've highlighted, the soft skills that over 50 years ago, roughly about 50 years ago, that the military talked about. And here that I've listed, and this comes from the presentation on December 13th that Lieutenant Colonel James Sewell presented this at the Soft Skills Conference, highlighted. And I've listed the qualities that we need to be identifying, and I took the liberty of just in the bold and parenthetical are things that I think that should be added. And the 5 components of emotional intelligence, I think, is real critical. And this comes from Professor Daniel Goleman out of his 2006 book on social intelligence, The New Science of Human Relations. And the 5 components of emotional intelligence very quickly are self-awareness, self-regulation, internal motivation, empathy, and social skills. And so really what this boils down to is that we need to hire a different type of public health practitioner, not only as a DIS, but in leadership. And we also need to have a different level of training. Next slide, please. And so with that, going back to Adam Grant's book, Think Again, of Learn, Unlearn, and Relearn. If done correctly, if we do this correctly, and again, want to just quote from a philosopher, professor at University of Oregon, Mark Johnson, no relation, and he states, and I quote, a full-bodied, full-blooded, fully passionate process that reaches down into the visceral depths of our incarnate experience and connects us functionally to our physical and cultural world is how we're going to be able to do this. And so really what this boils down to and what he's getting at is we need public health practitioners, that being DIS, community health workers, to be culturally literate, not culturally sensitive, but culturally literate. And this is where health professionals will have the necessary soft skills and technical expertise to understand the social risk. Underserved and marginalized communities are confronted by thus avoiding faux pas, missteps, alienation by individual blaming and shaming persons from underserved and disenfranchised populations. And really, the whole concept for me on resonating on cultural literacy comes from an op-ed piece out of the Washington Post from Batash Adi, who is an Afghan interpreter, did this for 15 years. And so this was an article last month in the Washington Post. And the thing where cultural literacy is so important on the faux pas, where we don't make the missteps. And this was highlighted on what happened at the border, where the whole notion, because people were coming from Central America and Mexico, the thought was that they speak Spanish, not understanding the Indian dialect that a number of people spoke. And so there were challenges there where they did not have people that could interpret because of these kinds of cultural illiteracy on our part. Another faux pas and misstep that can happen comes from Precious Brady Davis in her book, I've Always Been Me. And this is a trans femme woman of color, talks about her trans masculine husband who was pregnant at the time, and the looks that they received in going to OBGYN. And again, the faux pas and missteps and the shaming that took place there. And so when we're culturally literate as opposed to culturally sensitive, we do not end up making these kinds of mistakes, or we greatly minimize them. And so as I was sharing with you, the understanding the social risk, and this is not a foreign concept. The U.S. Preventative Services Task Force, in an article that came out this year in 2021, Incorporation of Social Risk in U.S. Preventative Services Task Force recommendations, they state, and I quote, incorporating social risk such as food insecurity, housing, interpersonal violence into clinical preventative services, and focusing on them as a topic at our opportunities to improve health outcomes and achieve health equity. And so this approach has gained traction in the medical and in the law schools. Professor Lee Goodmark at the University of Baltimore School of Law, in a paper that she put forward, and she states in the paper, learning more about how marginalized communities experience domestic violence from the people experiencing it would be a good place to start in rebuilding our systemic response to intimate partner abuse. Professor Paula Gerber at Monash University in Australia, and Claren O'Hare at the University of Melbourne, who do a lot of work around researching queer theory and law, in a 2019 paper, put forward this, and I quote, teaching sexual health must cover the importance of terminology, diversity and identities, and perspectives, and embrace a comprehensive approach. Sexual health cannot be divorced from the society in which it operates, and that it helps to construct, unquote. And then finally,
David, we are really going over. Are we getting close to the end?
Yes, we are.
Thank you.
Okay. Columbia University College of Physicians and Surgeons put forward here, they've got a program of narrative medicine, and the goal is to reimagine healthcare based on trust and trustworthiness, humility, and mutual recognition. Next slide, please. And so here, the important thing here from Professor Hickman, the professor at University of Chicago, an economic professor, is really what it boils down to: an action is right only if it is right for all people in all situations. And what he means by that is using soft skills, we develop policies that really impact all. An example would be the Affordable Care Act, the expanded SNAP benefits, the advanced child care tax credit, free COVID-19 vaccinations, and community outreach, such as the Panola Project in Panola, Alabama, where Dorothy Oliver and Drusilla Jackson were able to get 97% of the residents in Panola, Alabama vaccinated against COVID-19. Next slide. So in closing here, and really what it comes down to is that being more inclusive, more resilient, and what I'll just kind of end with, we can publish a lot of papers in this world, but if we do not produce public policies and laws that make communities stronger, kinder, more inclusive, and more resilient, then it ain't gonna happen. And so this work is going to require both bold imagination and fearlessness. And this can only be done if we invest in soft skills, but we have to remember soft skills are awfully darn hard to do. Thank you.
And we are now about to start the afternoon session. If you missed that because it wasn't recorded, I said good afternoon, everybody, and for some of you still good morning. We have 4 presenters today. We are going to have this session on the organization and structure and context for DIS teams from 2 o'clock to 3 o'clock. And we will follow that with a panel from 3 to 4, which Joe Valentine will be moderating. I am going to hand off quickly to the next slide, please. I'm going to hand off to the next speaker quickly. I would like to say that we had a speaker from Louisiana originally in this presentation, and our thoughts go out to the Louisiana program and everyone in Louisiana and several other states for the effects of Hurricane Ida. And I would also like to point out that our next speaker performed particular heroics putting something together. Stephen Kovaleski put this together in about 3 days, coming in our special request to give this talk. So, Steve, over to you.
All right, thank you. So I'm Steve Kovaleski with the State of Pennsylvania, Senior Public Health Advisor. Next slide. So for some context, we were looking at individuals 15 to 24 years of age. And one of the frustrations that we were having with individuals that were having repeat infections. And we began to look at individuals that had multiple STDs, and in particular, individuals that were going on to their 4th STD. One of the things that we noticed is that individuals who went on to develop HIV after that 4th STD, the mean number of months from that 4th STD to them acquiring HIV was about 6 months. And so we began thinking is that what could be done from a programmatic level to have interventions in place to prevent that from occurring. So we looked at data in our PA-NED system, and we started to look at a subset of individuals that had already had 3 STDs, and then looking at when they acquired that 4th STD, and then when the HIV seroconverted. And as I stated, we found out that for those individuals seroconverting between the ages of 15 to 24, the mean number of months was about 5.84 months. Next slide. So we made some programmatic decisions that these individuals would be ideal candidates to enroll in PrEP. And that would involve our DIS services going out and locating these individuals, following up on their current STD, but also with the goal of linking them to PrEP services. As I indicated earlier in the slide, about 6 months was that critical time period from that 4th infection to when that individual acquired HIV. So getting an individual out there as soon as possible was very critical, especially getting them enrolled into PrEP. We do know from history that many of these individuals in this age group do not have a regular medical home. Preventive medical care is just not part of their overall medical paradigm. They're just not thinking about the long-term medical situations that they find themselves into. As such, this age group often requires medical services through urgent cares, emergency rooms, and et cetera. One of the misfortunes of this is that medical staff in these settings do not have a complete understanding of the client's actual risk for acquiring HIV, nor their past history of STD. So it's rather a fragmented approach to healthcare. Next slide. So we began looking at our data, and we were using SAS as a predominant means to generate these lists. And we began to analyze 22 years of historical STD surveillance data to identify high-risk populations by county. And what we began to look at is only individuals with at least 3 previous STD occurrences. And anytime they received a new STD diagnosis, if it exceeded that 3 and they're on their 4th STD, we considered them to be a candidate for PrEP follow-up. Field staff use this natural intersection approach to offer PrEP, meaning the field staff only contact a candidate after a new STD is reported to the DOH as standard procedure. One of the things that we looked at, there were many individuals in our system that have 8, 9, 10 STDs and remarkably are still HIV negative. You know, what do we do with those individuals? So a decision was made, we were only going forth when a new STD was reported. From those populations identified, only those individuals who are documented HIV negative and not enrolled in PrEP are considered candidates for this PrEP referral mechanism. Next slide. So we generate this list of individuals that are eligible as candidates for PrEP. However, the local supervisor can still make a decision if this individual is going to be enrolled in the field follow-up for PrEP. And that includes things like the CDC PrEP guidance for risk factors, age, gender, and geography. Any individual named as a contact or associate or suspect or having a reactive test for syphilis is also considered a high priority. Next slide, please. So we do know that with HIV, individuals are at higher risk with an STD. I'm using the CDC model right now and showing you a little bit of a risk factors between different candidates. If somebody is in acute HIV and has no STD, their risk of acquiring HIV for the non-infected individual is about 7 times riskier if they're having receptive anal intercourse. If we add STDs to that, that risk jumps to 19 times higher. So we do know that as controlling an individual's STD infections and acquiring additional infections, we're also have the ability to reduce the risk of HIV transmission. And if we can get that partner who is not HIV positive onto PrEP, we further reduce that risk. That was the driving factor about using this data to initiate PrEP or field follow-up, is to reduce the transmission possibilities and also reduce the overall risk for the individual who is not HIV positive. Next slide, please. So I have 4 case examples I'd like to share with you that if we had PrEP, some of the interventions that we could have done around these situations. So the first example is a male, age 20, and these are real life examples that came from our surveillance system. If we had this system in place back in 2015, conceivably, we could have intervened 15 months prior to that individual becoming HIV positive. The individual first appeared in our system in 2013 with a gonorrhea positive. He was treated, and then subsequently in August of 2015, he was also positive for gonorrhea and chlamydia again and treated. In September 2015, he reacquired gonorrhea, and that's based on our new model. That's when we would intervene with PrEP intervention. However, we did not have that, and the individual went on to develop gonorrhea and chlamydia in February of 16, once again in May of 16, and then November of 16. And unfortunately, in December 2016, he was HIV positive. Next slide, please. Another example is a male, age 29, very similar story. The individual first appeared in our system in January 2013 with a chlamydia, was reinfected with gonorrhea in July, and in May 2014, the individual unfortunately had secondary syphilis and chlamydia. At that point, if we had PrEP intervention, we would have intervened at that point in time. Unfortunately, this model was not in place at that time, and the individual went on to develop gonorrhea in November of 14, gonorrhea in March of 15, gonorrhea January 16, and in June 2016, he was HIV positive. And unfortunately, the individual went on in August 2016 to develop gonorrhea and chlamydia as well. Next example, please. Next slide. One of the things that surprised us with our data is that the number of females that were eligible for PrEP once we start looking at this model of 3 infections and getting this 4th STD. It turns out about 50% of the individuals that were enrolling in PrEP are females, which was a surprise. So in this example, this is a female age 23. If we had PrEP intervention, we would have intervened approximately 16 months prior to her becoming HIV positive. One of the take-home messages here with this PrEP intervention is that it's not only preventing and getting an individual enrolled into PrEP, but the future STDs that we're seeing, the February 2016, the April 2016, the November 2016 chlamydia, would we have had an opportunity to intervene in those as well? Next slide. And the final example is another individual, male, age 29. Again, if we had had this PrEP intervention, we would have intervened about 15 months prior to their HIV positive. Next slide, please. So this is a little bit of an 18-month sample that we took. And as you can see, our primary focus was those individuals that had 4 STDs. So they had 3 STDs waiting, and they got that 4th STD. In an 18-month period of time, it was about 447 individuals. We would have liked to enroll individuals at 3 STDs, but the number that you're seeing there, approximately 1,746 individuals, was far greater than the number of resources that we had for DIS to follow. So a decision was made to follow up on these individuals at the 4th STD. And unfortunately, you can see through the data that we have some individuals that are on 6, 7, 8, and one individual that remarkably at 11 STDs was still documented as not HIV positive. Next slide. So this program has had many benefits for the HIV STD program. One of the key opportunities has been enhanced disease intervention opportunities as it relates to partner services. Normally in the state of Pennsylvania, there are a large proportion of gonorrhea and chlamydia cases that we would not follow for DIS services because simply don't have the resources. By implementing this model, this is an individuals that we are now following up on. This provides an opportunity to notify others of exposure to HIV and STD, and also again, offer them PrEP to their contacts. It also has provided an opportunity to provide expanded HIV testing, potentially identifying HIV-infected individuals who do not know their status. And we do know from looking at our data that individuals that have a high rate of repeat STDs are also at a much higher rate of co-infection for HIV, as high as 13%. It also provides opportunities to link these to these much higher risk clients to care and get them into a continuity of care model rather than going to urgent cares and emergency rooms. And also gather important information about their risk factors. Why is it that we see one individual only one time in their life for an STD, while other individuals have up to 8 STDs? So gathering that risk information is very important. It also allows for a referral of high-risk clients for more comprehensive STD services, such as full clinical examination, syphilis testing, etc. Next slide. Again, some additional risk for the patients linked to PrEP. It reduces the period of STD infectiousness. So once an individual is enrolled in PrEP, they're getting testing every 3 months, to measure the toxicity of the drugs, but also at each visit, they're getting a full STD workup. So individuals, rather than having an STD perhaps for 6, 7, 8 months and being untested for that, they're getting a test every 3 months, and as a result, getting a quicker treatment, which also reduces their period of infectiousness. At each PrEP visit, they're also getting a risk reduction message from the provider, and those recurring risk reduction messages is hopefully moving that individual along the continuum of less risk. DIS also work proactively with PrEP providers to make sure the risk reduction messages are on target. The individuals are self-reporting their risk, and we hope to measure that over the long term to see if risk is actually being reduced in this population. Next slide. All right, so how this works every day is that we produce a priority report to our field staff. Every DIS in the state of Pennsylvania gets this priority report automatically generated, and PrEP is part of that. So we get about 54,000 reports annually in our PA-NED system. For a DIS to go through and look for those priorities is just not humanly possible. So we use a SAS algorithm that goes through the system and generates individuals that are high priority. And you can see that this is labeled here. We have individuals that are gonorrhea PrEP, means that they are at least have 3 STDs with a brand new gonorrhea infection and are eligible for PrEP, as well as individuals that are HIV co-infected with gonorrhea and the such. So this is how this PrEP list is generated and how our DIS know what their priorities are for the day. Next slide, please. And then the outcomes of our PrEP for 2020. So of 9,970 individuals, 28% of them, when we identified them, were currently enrolled in PrEP. About 35% refused PrEP, even after we reached out to them and provided the education. One of the things that I want to identify here is there are new HIVs. We identified 4 additional individuals that were not known to the system that were HIV positive. And so I think it's an effective model of reaching out to individuals that are high risk, especially for giving them additional HIV testing. Next slide, please. So again, in summary, using surveillance data is essential to determining program priorities. We started off with a supposition is that individuals at their 4th STD were at higher risk for HIV. We pursued those hunches, we validated, we kept on asking questions of our data. And then we also looked for opportunities to put those findings into actionable items. And with that, I'd like to turn it over to Chang.
Great, thank you, Matthew. So good afternoon, everyone. I'm Dave Kern, and I'll be talking about how Chicago prioritized partnerships and equity in our COVID case investigations and contact tracing response. Next slide. I'll share context for our model, talk through model design, share outcomes, discuss some future work that we will be doing, and conclude with key takeaways. Next slide. Chicago's COVID case investigations and contact tracing response, like all of our public health work, is guided by Healthy Chicago 2025, which is our local public health improvement plan. This plan has one central aim, and that is to reduce the life expectancy gap between white and Black Chicagoans, which stood at 9 years before COVID emerged. The Chicago Department of Public Health, or CDPH for short, has been providing some level of case investigations and contact tracing since first cases were diagnosed in early 2020. As case numbers grew, we developed a multi-sector model to manage volume and to promote health and racial equity in our COVID response. The unified model includes 3 groups, CDPH and city employees, healthcare partners, and community-based organizations. Next slide. For context, by fall of last year, we had over 700 people working on case investigations and contact tracing. Today, the current team works 7 days a week, 12 hours a day, and includes more than 900 people. The team was built intentionally to be flexible, allowing efforts to shift to other COVID response activities as needs changed with the pandemic. And I'll say that our multi-sector response may have been more challenging to implement than wholesale outsourcing of this work or a massive expansion of the CDPH workforce, but it allowed us to make significant and meaningful investments in our local communities and allowed community members to actively contribute to the city's COVID response. And the multi-sector model positions us, we believe, to create a sustainable external public health workforce for the future. Next slide. Our response has 6 overarching goals: reaching contacts quickly, ideally within 3 days of the index cases test, achieving a contact index of greater than 2, increasing the percentage of contacts who test and immediately and successfully quarantine, and in keeping with Healthy Chicago 2025, promoting health equity, supporting recovery in communities hardest hit by COVID and least likely to see quick economic recovery, and building a sustainable public health workforce. Next slide. Because of case volume and challenges reaching all confirmed COVID cases, all persons with a confirmed COVID case for which we have contact information received an automated call and the blue box immediately to the right of the positive COVID test diamond. This allows us to reach almost all cases with public health guidance, instructions for self-notifying contacts, and the opportunity to request resources to address needs that may impede successful isolation. In our unified response model, our first line of in-person engagement is through our participating healthcare providers, represented here in green. These facilities provide case investigations and contact tracing for their own patient populations. If a person is diagnosed through a partner that doesn't have the capacity to provide its own case investigations and contact tracing, CDPH provides the case investigation, which we consider our second line of in-person engagement. CDPH activities are highlighted here in blue. And we also provide facility and special case investigations. Any contacts that are elicited through CDPH case investigations are then assigned to our community-based contact tracers, highlighted in purple, who notify contacts and provide ongoing surveillance monitoring through the quarantine period. Our community-based partners also provide resource coordination for our entire unified response, and this is highlighted in orange. Now I'll provide a bit more information about each of these sectors. Next slide. So again, our participating healthcare partners are the first line of engagement for confirmed COVID cases. This program launched in December of 2020 and includes 28 partner organizations, specifically federally qualified health centers and hospitals. The program employs a workforce of about 150 team members, a majority of whom are Black and Latinx, and we're currently investing about $15 million in this program. So why did we choose healthcare partners? Well, first, it allowed us to reach more cases and contacts by expanding the number of individuals who were providing case investigations and contact notification. Second, engagement strategies can be tailored to specific patient populations and community areas served by our healthcare partners, federally qualified health centers in particular. And third, healthcare providers build trust and rapport with their patients, which we believed would increase successful interviews with index cases. Next slide. CDPH's case investigators are, again, the second line of in-person engagement for confirmed COVID cases, working those cases diagnosed outside the participating healthcare partners. CDPH's work in this space started around August 2020 and has a workforce of about 134 team members, a majority of which are Black. For the first 5 months, both case investigations and contact tracing were conducted by CDPH alone as these other programs came online. Once the community-based contact tracing core, which we'll talk about next, was launched, CDPH phased out of the contact tracing work. Next slide. The contact tracing core notifies contacts elicited by CDPH case investigators and provides surveillance monitoring to contacts through quarantine. This includes work with the Chicago Public Schools to provide rapid notification to close contacts identified by the school system. This program launched in September of 2020 and includes 31 partner organizations and with a workforce of about 600 individuals, a majority of whom are Black. We are currently investing $56 million in this program. Community-based contact tracing core partners are community-based organizations that are located in high economic hardship community areas around the city. Core members include residents with limited formal education or training and residents who were previously justice involved. So core members are able to bring their lived experiences and innate sensitivity to this work. Core members are paid above living wage, $20 to $24 an hour, and receive in-depth initial training and ongoing professional development. Our core members are also invited to participate in our Earn and Learn initiative, which promotes career pathways and long-term sustainable income growth for these folks. Core members get 1 paid day off each week to attend classes at no cost towards certification or degree programs through the city colleges of Chicago. Next slide. The Resource Coordination Hub connects index cases and contacts to resources to support successful isolation and quarantine. The program launched in September of 2020 and includes 1 partner organization and a workforce of 32, a majority of whom are Black. The Resource Hub is funded as part of a $56 million investment in the community-based contact tracing core. Since January of this year, the hub has served more than 6,000 Chicago residents, and the most common needs, have been food and emergency financial assistance for rent, mortgage, and utilities. Next slide. To keep the multi-sector response coordinated, all partners complete standardized trainings, follow the same case investigation and contact notification scripts, and collect and report data through a common data platform, Salesforce. Each external program in the unified response is led by members of the CDPH HIV STI leadership team. So for example, the HIV Healthcare Access Director leads the healthcare program, our Community Development Director leads the community-based contact tracing core, and our HIV Housing Director leads the hub. These leads meet regularly with the CDPH case investigation lead to further coordinate efforts across the sectors. Next slide. So now let's look at some of the outcomes of our work. I want to draw your attention to the black box, which highlights outcomes of our automated calls and texts that were sent to all confirmed COVID cases. Again, the calls and text include public health guidance, information about self-notification of contacts, and links to resources via an online survey. 90% of cases received the calls and texts, which means we are able to reach far more people than we could through in-person case investigation alone. And about 5% responded to the survey to receive resource support, about 5,300 people through late August. Now look to the final column in the table, which summarizes % of cases successfully interviewed by organization type between December 27, 2020 and May 29, 2021. You'll see that the CDPH case investigators completed just over 1/3 of all case investigation interviews. In comparison, healthcare case investigators completed nearly 2/3, which I've highlighted in yellow. While healthcare partners only accounted for about 15% of overall cases for this time period, their rate of interview completion was twice that of our internal CDPH team. So overall, just under 40% of index cases had interviews completed for this time period. Next slide. Looking to the black box, you'll see that the CDPH case investigators had a contact index of 2.1, while healthcare partners had an index of 0.5. This signals an opportunity to work with healthcare partners to improve their contact elicitation. Looking at the final column in the table, which summarizes % of identified contacts that were notified by organization type. The community-based contact tracing core managed a vast majority of contact engagements, over 70%, and were able to notify about 37% of contacts. CDPH conducted some contact notification as well and reached about 45% of these folks. In comparison, healthcare partners, while their contact index was lower, notified over 61% of elicited contacts. Again, highlighted here in yellow, which is more than 1.5 times as many as the community-based contact tracing core. Next slide. We also looked at timeliness of case investigation interviews and contact notification, and we observed no real differences between organization types. All partners completed interviews in an average of 3 days and notified contacts in 1 day or less. Next slide. Case investigations and contact tracing is an important part of Chicago's overall COVID response, but like many jurisdictions, we struggled with appropriate staffing as COVID waned and surged to reach enough contacts in a timely manner to have a population level impact. What's not represented in the data is other important work that the CDPH case investigations team conducted. The team identified more than 1,000 outbreaks and clusters and played an important role in investigating these and other priority cases like pediatric cases and breakthrough cases. Our outcome data suggests that case investigations and contact tracing provided through healthcare facilities was as good as, and in some cases better than, public health delivered case investigation and contact tracing. Next slide. Right now, let's spend just a few minutes talking about how each sector's work has evolved or will evolve in 2021 from a singular focus on case investigation, contact tracing, and/or resource coordination to other important parts of our COVID response. Again, this flexibility was intentionally built into the model design. In 2021, with our funding, healthcare partners will continue providing case investigations and contact tracing for their own patient populations and will initiate new programming for linking and re-engaging patients to care and wraparound services as trusted institutions in their communities. And they will initiate education and outreach in community and home-based settings within the catchment area that they serve. Next slide. The CDPH team will continue providing case investigations and will resume contact tracing and surveillance monitoring as the community-based contact tracing core transitions to new work, which I'll talk about next. Next slide. The core, again, will continue contact tracing through this current surge and then transition that work to CDPH after. The contact tracing core has already stood up our COVID call center in conjunction with the resource hub. I'll talk about that on the next slide. Has already initiated door-to-door and event-based canvassing, knocking on over 11,000 doors in priority neighborhoods across the city, and has implemented community health work strategies like Promotores de Salud, which helps us engage in person members of our Latinx communities. And again, this was possible because the workforce is made up of members of the communities that we need to serve. Next slide. And finally, the resource coordination team has already stood up the COVID call center. And to date, the call center has received more than 250,000 inbound calls and made more than 46,000 outbound calls. Services include response to general COVID inquiries, vaccination scheduling, and proactive engagement of unvaccinated residents, including members of our Medicare population and individuals that have a flu vaccination on record, but not a COVID vaccination. The hub will soon initiate hyper-local resource inventories and work with communities and funders to develop new and needed resources within these hyperlocal neighborhoods around the city. And finally, with other partners, primarily in the behavioral health space, the hub will continue to build toward the development of a 211 system for the city, something we don't have right now, using the COVID call center and the hub as the foundation. Next slide. So to close, I'll share a few of our key takeaways. Overall, COVID response has created a new energy at all levels about refreshing partner services and disease investigation work. We're already looking to translate lessons learned and promising practices from COVID into our HIV, STI, viral hepatitis, and TB responses. Choosing a path centered on health and racial equity and partnerships strengthened our ability to respond to COVID, both through case investigations and contact tracing and beyond. It allowed us to partner with local healthcare institutions and community-based organizations, and to hire and train a sizable number of residents from high economic hardship community areas, allowing COVID funding to flow directly into these communities. And our response benefited greatly from their expertise and community understanding. Flexibility allowed the workforce to fulfill critical non-case investigations needs in our overall COVID response. This includes the COVID call center, which again has managed hundreds of thousands of calls, vaccine navigation and vaccine appointment scheduling for residents, and hyper-local community engagement. Because we engaged partners in this multi-sector model, we had a trained and available workforce to address these and other emerging COVID needs. We've proven, we believe, that case investigations and contact tracing delivered through healthcare facilities can be as effective at reaching index cases and elicited contacts as governmental public health, and in some cases more so. We know that our healthcare facilities are natural partners, and we're committed to leveraging the successes we've seen in COVID to expand into other public health interventions, for example, HIV, STI partner services, and hepatitis linkage to care and case management. And I'll close with one point of privilege. I want to send my heartfelt thanks to the Chicago COVID case investigations and contact tracing team, including members of the HIV, STI, and CDC field teams who stepped in early on and continue to actively support this large and complicated effort. And thanks to the healthcare and community-based teams that stepped up to learn and to provide a new set of interventions, and who were flexible when we needed them to pivot to other important COVID work. Certainly we would not be where we are today were it for this incredible team. This concludes my presentation, and our next speaker is Darpin Sachdev from the San Francisco Department of Health.
Thanks so much. I'm Darpin Sachdev. I'm an infectious disease specialist at the San Francisco Department of Public Health, and in my pre-COVID role, led our HIV and syphilis contact tracing teams. And since COVID, have been leading our COVID contact tracing program. I want to really thank the conference organizers for the opportunity to share our experience in San Francisco. I'm hoping to really weave together lots of the themes that have already been mentioned throughout the course of the day in sharing our San Francisco experience. So I can go ahead and just start talking through. So as in our role of providing syphilis partner services, in the last 5 years, we've seen rapidly increasing rates of syphilis in San Francisco. And at the same time, in terms of disease intervention outcomes, we've seen them decreasing. We can go to the next slide. And so in, I think around 2018, we decided to better understand what was behind this phenomena. And we conducted a series of qualitative interviews, not only with our DIS, but also with clients to understand the factors that were related to declining syphilis interview rates, the lower proportion of cases naming partners, and to begin to identify better practices in order to improve our outcomes. Next slide. What we learned by interviewing our DIS was that they wear many hats. Many of them come from no disease intervention experience, and they are tasked with being syphilis experts, with being detectives, teachers, therapists, public health warriors, customer service experts, and having to keep everything organized all the time. Next slide. As we spoke with clients who had been outreached to for syphilis partner services, we found that particularly among those who had been interviewed but chose to not name any partners, they actually expressed to us that they were interested and often would self-notify their partners. And they commented about the opportunity that we had to improve the tone of the conversation between the DIS and the patient in order to improve customer experience and satisfaction. When we talked to those who had been interviewed and named partners, they actually commented that they would sometimes name someone just out of their own exasperation of their DIS experience. And many of them also commented that they often would self-notify on top of informing us of their partners. Next slide. So within all of these data that were collected, we began to really think about the syphilis journey. That was not just our interaction with a patient at the completion of their diagnosis and treatment, but it started really before the diagnosis, continued onward when they were diagnosed, and then we followed up at a later point. And by thinking about these different phases, we were able to think about different interventions that could be offered, particularly technological improvements that it could occur early in the spectrum, but also how we were operating at the time that we would meet the patient, particularly what we were trying to accomplish and how we could improve our ability to engage non-judgmentally with individuals. Next slide. And so here we were sort of at a crossroads, recognizing that we had a choice to either lean in further to increasing the number of named contacts and the proportion of cases who named contacts, or we could step back and begin to redefine our objectives and metrics and overall update and improve the experience between the patients and the DIS. Next slide. So we chose the latter. We chose to step back and redefine our metrics and our approaches. We sought out to create high intensity and low intensity approaches based on the type of population we were working on and known outcomes within and preferences within those populations. We also sought out to develop better trainings, in particularly a sexual health coaching training that was administered in late 2020, and opportunities to better capture when a client reported to us that they wanted to self-disclose. So we were giving tools to our DIS in order to encourage self-notification instead of trying to force a named partner. We also sought to develop an improved training curriculum that was stepwise and in which staff could earn badges as they moved up into higher levels of scope and responsibility. We also, recognizing the need for trauma-informed care, offered clinical supervision for our staff. And then finally, we really recognized the opportunity for technology, particularly in notifying partners anonymously and improving data collection, but we weren't necessarily able to realize that yet. Next slide. So then along came COVID. And in San Francisco, we were one of the first jurisdictions to initiate COVID-19 contact tracing in April 2020 by independently contracting with an electronic platform to support our data management. What we found that if you build it, they will come. So for the first time in my experience, red tape was removed entirely, and we had the financial, human, and technological resources to do the work. What we found out of this investment is that we were able to scale a CICT workforce with non-clinical city health workers, city workers, particularly librarians. We created a robust training program. And then finally, we were able to leverage technology in new ways. And in particular, I'll discuss a chatbot that we utilized. Next slide. So very similar to the Chicago experience that has been discussed, we needed to start by building our workforce, and we prioritized language concordance and people who were from affected communities. We then sought to further train and develop our workforce, focusing on the soft skills that David Johnson mentioned earlier. And we did this through the lens of continuous improvement and quality assurance. We offered individualized coaching and mentorship to our newly trained health workers who are providing case investigation and contact tracing. And then within this whole context of working in a brand new way of doing the work virtually, we sought to foster resilience and engage our staff socially and sustainably. We also sought to really build out and support community-based organizations. Next slide. At the same time as we built the workforce, we also wanted to see what we were accomplishing and better identify if our metrics were reflecting the work that was being invested. We ended up analyzing our data very similarly to the way that we've previously looked at syphilis contact tracing outcomes by focusing on the percent of persons who were interviewed, those that named contacts, those contacts that actually got tested, and identifying the number of new contacts that were identified as newly diagnosed with COVID-19. So case finding, very similar to what Dr. Golden highlighted earlier this morning. We ended up publishing our early results in JAMA Internal Medicine. Next slide. We also sought to leverage new tools that were offered. Within CalConnect, California's COVID-19 case management and contact tracing platform, Accenture developed an automated, integrated chatbot technology, which allowed cases and contacts to respond to us almost immediately if they needed support with isolation and quarantine, and also provide us some basic data regarding their symptoms, comorbidities, and if they had any contacts that they would want us to inform. Next slide. We implemented this chatbot technology in November of 2020, right before the winter surge. And what we sought out to understand is that if we were implementing the chatbot across the board to all cases, if we could then decrease the amount of phone calls that we needed to make, particularly in the setting where we had not enough staff to make all the phone calls necessary. So if you compare the fall 2020 period with our winter surge, we saw a 400% increase in cases. At the same time, we only had a 20% increase in our case investigation staff. What we saw here is that by implementing the chatbot across the board, overall, our interview rates did not drop precipitously. They went from 85% of cases interviewed down to 75%, so 10% decrease. And when we looked further, focusing in on our Latinx population that had overall been disproportionately infected in San Francisco, we found that there was a smaller reduction in those who were interviewed, going from over 90% to 87%. What we did see, though, with implementation of the chatbot is that overall fewer contacts were named. And this is, always going to be a challenge, but it's understandable that interfacing with a chatbot led to fewer people naming contacts that they may have been associated with. Regardless, by implementing the chatbot, we were able to reduce the number of calls that we had to make by 30% and really focus in on one of our key populations where we sought to provide isolation and quarantine support services. Next slide. So just to speak overall, very similar to Chicago, what our metrics were looking back at a year's worth of contact tracing investment. We interviewed 79% of all of our cases, and 60% were interviewed within 24 hours of receiving the test results. Overall, about 40% of those interviewed named at least one contact, and we were able to successfully reach 80% of the contacts named and offer quarantine and resources. One thing that remains challenging for all of us is to really measure adherence to isolation and quarantine recommendations. So I don't have data reflective of that. Next slide. But as we've been noticing the ongoing surges of the last few months in COVID-19, I feel like we're again at another tipping point. We're seeing our contact tracing outcomes decline as COVID surges occur. We're also seeing decreased contacts identified in the setting of reopening. This is all on top of just very unavoidable challenges with contact tracing and COVID-19, which include that over half of our transmissions are asymptomatic or pre-symptomatic. And that oftentimes by the time we get to household contacts, they're already positive. And that overall it's been challenging to identify contacts in super spreader events. Next slide. But despite all of this, we've really accomplished a lot 1 year later in order to develop our workforce and address burnout, prepare for surges by flexing up our local staff as well as state staff, but it's always been challenging to flex down, building a racially diverse, ethnically concordant, community-based workforce by directly funding our CBO partners, and building out a bilingual Spanish-speaking workforce, which was about 40% of all of our staff. We've also identified important isolation and quarantine supports like Right to Recover, which was financial assistance for those who did not have sick pay. We also leveraged technology, as I've mentioned, in new ways with the chatbot. And finally, we really put contact tracing on the public's radar through frequent media interviews and encouraging people to answer our calls. Next slide. And so finally, I really want to highlight here what I mean by Delta is not just a variant, it's the norm. Delta, as many people remember from math and physics, means change. And we really have to begin to embrace that change as we're moving forward. For us, COVID-19 offered an opportunity to realize a bold new vision for disease intervention. And our challenge now is how do we redefine our goals as we move forward? Next slide. And so where we are now in San Francisco around contact tracing for COVID-19 is that we're really, again, at this tipping point where cases are increasing. It's harder to reach cases. It's harder to identify contacts. Delta's working faster, but case investigation isn't. We're seeing more of an importance and need to focus on schools, shelters, and SNFs, what we call the 3 S's here. And despite high transmission, particularly in a city like San Francisco, where 80% of eligible people are vaccinated, we are seeing low hospitalizations and deaths. So everything has changed. But some things that we've learned importantly are that our support services are valued, that we can utilize our chatbot technology, communicate with people quickly, and that overall we do continue to identify higher rate of new positives by doing contact tracing than community testing. Next slide. And so again, we're at another crossroads. Do we keep doing this work, identifying and lean into identifying more contacts, or do we redefine our objectives in the overall experience? Next slide. And overall, we are again shifting and leaning into more automated ways of doing this work and decreasing the manual work. Next slide. And I just do want to highlight again on the theme of change, Delta, is that we really do need to keep supporting our staff as we're considering change in the coming years with new funding. We found that this is best done through frequent meetings, transparency, and humility. Next slide. And so again, we've gone back to our DIS and supervisors and asked them, what do we need to do differently? Where do we need to invest? And you can see several keywords here that were named during these interviews that have been mentioned throughout the course of today. Next slide. And so with our supplemental funding, we're seeking to build on our lessons learned. So we're creating a new quality and performance management team to focus on metrics. We're also dedicating a team for training, DEI initiatives, and creating new entry-level positions through a DIS fellowship, trying to build the infrastructures. And then finally, really beginning to embrace a culture of resiliency and innovation by offering more promotive opportunities for our existing staff to develop new skills, and then also creating more rotations for existing DIS to work across their silos. And so thank you so much for your time. I'm hoping that we can pass off to Chang.
Next slide. The map that you all see is a map of Kentucky. As you can see, even though Kentucky is not a big state, it has 120 counties. And what you see at the top and the bottom on the side are the health districts that we have in the Commonwealth. Next slide. The needs. like I said, we have 120 counties in the Commonwealth, and they operate semi-independently from the state office. They accept certain technical assistance, guidance, and more importantly, money from the state, but more or less they set their own agendas and they have their own way of doing business. When we started this outbreak response that happened in Jefferson County, which is in Louisville, there were only 8 DIS, and bit of footnote, this outbreak response started in late June, early part of July. We are now up to 11 DIS, but when we started, we only had 8 DIS throughout the state. And bulk of them are located in high morbidity areas, especially in Louisville and Lexington area. And as you can see at the bottom, Louisville is accountable for about 55 to 60% of all STDs report to CDC on an annual basis out of 120 counties. We have some counties, smaller counties out in the east and the southern part of the state where they have no STDs reported, not even a single case of chlamydia. So it's very different from city to city to region to region. Next slide. Responding when called upon. When we hire a new staff to the program, we make it clear to them that even though you're going to be stationed in certain parts of the state, there may be a time when you're called upon to go to a different part of the state to work an investigation. So it is relates to them at the early part of their career that they may be called upon to go somewhere else. We don't want to be someone that comes up, tell someone as a surprise and want to give them plenty of time to be prepared. And we also provide essential training that they're going to need. We make it mandatory for all our DIs to be phlebotomy trained. And I consider this to be a critical skill set all DIs should have. And so we make sure they're fully trained on that before they're assigned to any area. Familiarization with the area. All the folks that we hire normally are from Kentucky, and they are from the area they're going to be working in. So they're very familiar with the area they're going to be working in. And we kind of emphasize the model of working together during our annual retreat. We have a retreat every summer around August or September when we bring all the DIS in the Commonwealth to the state office, and we have a day of retreat, going over things, learning about new things, meeting new people. We haven't had that in 2020, but we will have it again this year. And we identify ongoing training needs for the staff. I usually get feedbacks from the supervisors in the area to let me know what kind of training their staff needs, and we forward that to the other people who can actually conduct their training, and buy-in from local health departments. When we assign people to other areas, that means that we're going to be pulling someone who's working in certain parts of the state to provide disease intervention services. So we need to get a buy-in from the local health department that there's going to be a time when your staff might not be there to provide the support they would need to provide. Next slide, please. Since all staff are local, the assimilation period, like bringing in people from outside, we don't have that issue when you bring in local staff in. They know the environment they're in, and they're very familiar with areas they're going to be in. And on top of that, they're already familiar with each other by working together, not face-to-face, but being on the phone, interacting when they have a different investigation, different parts of the state. So they already know each other. And there is no need to train them on a new system. We all use one system, and they're already familiar with it. So there is no really a time that's devoted to getting to know someone, putting them in a new training system, and line of communication has already been set. So we already have clear understanding of what each other is supposed to do, who they report to, and how it's going to be communicated from top to bottom and bottom to top. Slide, please. Some of the challenges that we experienced during the outbreak was keeping local health departments informed, which means that some of the cases that should be investigated, it's not going to be investigated in a timely manner because we had pulled our staff to the area that needs to be focused on, so they did not have the staff necessary to provide the STD deliverables, such like primary syphilis cases, secondary syphilis cases that had to be interviewed by a certain time frame, had to be delayed somewhat till we could get people back on the board. And having only 8 DIS made that challenge even more pronounced because we simply could not provide that same service to all 120 counties at the time. And one of the challenges that Kobe brought was that not all employees that we have in the state office and the field office were vaccinated. So we had to that concern. And some of the employees, because of their status and because of certain unknowns in the state, were unwilling to make certain field visits to certain parts of the city. And working with the local CBOs, we have very dedicated CBOs, but there's a territorial thing that happens when you encroach on someone else's area, so to speak. The outbreak was directly related to PWID cases among HIV, newly diagnosed HIV cases. And we have some CBOs in Louisville area who deal with that population directly. And that felt like we, the state, were encroaching in their territory, so to speak. So we had some issues with that. And lack of buy-in from other programs, such as we have a program out here in Kentucky that is identifying new cases. They were not willing to participate and work with us as far as, say, outreach activities were concerned. So we were kind of left to our own device as far as working with other CBOs and partners were concerned. Next slide, please. And to have 8 DIS and work on the outbreak, we had to make sure that burnout was not going to be a factor. So we rotated the staff on a monthly basis with the time off in between. And lots of these folks that we have asked to put their life on hold to go to different parts of the state, many of them have kids, and a lot of kids were still staying at home because of COVID. So we had to work around that issue. So we rotated on a monthly basis, and we made sure that to make their life easier, we authorized the use of fleet vehicles for all DIS who was going to be working on the outbreak. And over time, which was seldom authorized, I won't say never, but it's seldom authorized by the state, was authorized during the outbreak, including working on weekends. Next slide. One of the main reasons we were able to carry out the outbreak, and this started in end of June, beginning of July. I was just coming back from a TDY at the time, and we were able to contain the outbreak at this point. We had 27 new HIV cases that was directly related to IDU users, and we have, at the month of August, I have not gotten the September report, but as of August, we only had 1 new cases that's reported, and we have 11 cases that still need to be investigated. So it is still going on. There's something that's happening as we speak, but it is winding down. And one of the reasons that I believe it was successful is the STD program was able to share its burden among all staff. We just not asked the person, the DISs, to carry out this burden, but we asked our EPIs, we asked our surveillance coordinators, we asked our data entry clerks to pitch in to help in this endeavor. And they were all more than willing and more than happy to pitch in to make sure that whatever we needed to do to contain the outbreak was going to be done. And the Kentucky STD program is not a big program compared to other states. It's relatively a small program consisting of 15 total people at the state level. So we don't have lots of staff who's involved in day-to-day activities of STD prevention activities, but we came together on this when something like this happens, and we were able to put our resources together to make it work. And that goes to my point on the utilization of all staff is essential in making it work. Next slide. Lessons learned. I put prepare ahead because we didn't really prepare this ahead of time, even though because of Peach Grant, having a outbreak response team as one of the objectives has been in place for the last 3 years. Until now, we never really had to utilize it till now. So if you can plan ahead, if you have that luxury, I would definitely encourage you to plan ahead to make sure that you have your ducks in a row before you start deploying your folks, to make sure that whatever your staff needs are there and is met before they hit the ground running. we were able to do a couple of things ahead of time. We were able to secure lodging for all the staff before they reported. So unlike like when you go on the TDY for CDC, it takes time to get prepared, you know, lodging, preparing your travel order and all that. This came down relatively quick from the HIV prevention program because they noticed the trend that was going on in Louisville. So we were able to reach out to the hotels in the area to make lodgings for them as like over the weekend, basically, and have a vehicle, number of fleet vehicles that was ready to go and get picked up on Monday morning before they went off. So we had to do a couple of things on a last minute basis, but we were able to jump ahead to make sure that DIS had what they needed before they hit the ground running. And keeping employees informed. Every Friday, like tomorrow, on this coming Friday, we'll have after action report. We will discuss their weekly activities, cases they managed, people they were able to contact, the partners they were able to initiate. So we will have that on a weekly basis till this is done. And they're keeping me informed, and just as I'm keeping them informed of something that's coming down the pike, and constant monitoring. We have a good surveillance system, so we always monitor a number of new cases that's coming down, which means that even though we are still working on the outbreak, we have an idea of where other cases are coming. So we can be fully prepared to answer to those cases when this is all done, said and done. And there are multiple facets to ensuring successful outcome. Even though this was driven by the STD prevention program, and we are semi-integrated with the HIV prevention program, we work together, and their surveillance staff, our surveillance staff work together to make sure that we have successful outcome in the end. And I think I'm at my time.
Chang and everyone else, thank you very much for your presentations. We are indeed at time. I will dispense with any closing comments, except also to thank the senior management of the Disease Intervention Response Branch who were instrumental in facilitating this session for it. Joe, I believe this will be over to you.
Thanks, Matthew. So good afternoon, everyone. And I'm sure you can agree that we've had a rich conversation between this morning and this afternoon's presentations. So it's exciting to have a panel discussion and an opportunity to sort of give some of the panelists an opportunity to elaborate further on their perspectives as they've shared with us earlier today. So we have a set of submitted questions, and I'm going to stay with those questions. And I will not necessarily follow in the order that the questions are presented because I'm thinking about sort of how to build the conversation or build the discussion. So I'm going to start with you, Matthew, if you are available. So if I could ask the panelists to turn their cameras on so I can sort of know you're all there. The first question is, what would you consider the full range of disease interventions that a DIS team should manage if resources are provided? It's kind of the
you're right. I will be pumping this in short order, I assure you. But I would say, as I stare at a whole bunch of people who manage DIS programs, I would hope that they, at the very least, thinking about what everyone has presented today, that they would have, I think first and foremost, training and opportunity to practice those human interaction skills on it. We've heard several presentations, right? Not on those lines, both aimed at that, but also introducing that into the equation. I would say Dave Kern, for example, noting here that this is built into their COVID response, right? The community investment level. I'm just looking at some of my own notes there. Meaningful investment in communities. So I think that's probably a fundamental, and I suspect a lot of people agree with that. It's just not necessarily enumerated in the sort of the list of skills. I think absolutely you need to be able to handle STD and HIV. I very much appreciate what Matthew Golden spoke about earlier in terms of things like relinkage to care, that we do not confine our focus to new case finding. I think particularly for HIV, sometimes there are not that many new cases to find, but they are generated by people who, well, in networks of people who are already infected and need to be relinked to care.
Thank you. And so that's kind of is a nice way to segue to Matt Golden's presentation. But I wanted to ask you, Matt, what should be the organizational structure of DIS teams, getting at some of those points?
Are you asking me or Matt Hogman, or both?
I'm sorry. That's right. You are Matt Golden.
Yeah, I think that this is going to vary somewhat depending on the size of the jurisdiction. So very large jurisdictions are probably going to be dividing their teams up into sub-teams more, whereas very small, much smaller jurisdictions won't exactly have that luxury. I think one of the things we really need to be considering, though, is how we've organized the teams all together. In many ways, we've organized these teams the opposite of how we organize science and scientific research. So in scientific research, what you do is you put together an interdisciplinary team, not a team of people who all have the same discipline, right? That would be the kiss of death on an NIH grant application. And so would it make more sense to say I have a relinkage team or a syphilis team, and that has DIS, but it also has an epidemiologist on it, and it has some sort of supervisory structure, and it may have other people on it, and we allow people to develop expertise in a narrower range of work, and they develop a real commitment to that very specific body of work with associated monitoring metrics and someone they're working with. Of course, they need to be able to pivot in the event of an emergency to different work. So they're going to have to be cross-trained to some extent. But I think this is one of the things we all need to sort of be working through as we consider how we modernize this body of work.
Thank you. So as we're thinking through those kinds of things, Lucretia, I was wanting to ask you, how did you organize and supervise staff from different units and agencies with varied backgrounds?
Well, with us, we have a structure set up in our ICS. So with me, I have a co-lead who's from STI, Brian Toro, and under us, we have co-leads from each of the bureaus. So we have a lead from HIV, from STI, from TB, and immunizations. So they're the ones that work with the program to recruit the best staff from the program. They're the ones that help assign teams. We try to assign them by the bureau so that someone in HIV is supervising other HIV staff only because they know them and they work with them on a routine basis. It's easier to work with and assign them on, during an emergency. So that's how, so we have that structure set up in DOH. It became a little challenge when we brought in all these people from outside. And like from H&H, we received 12 case supervisors and 100 staff, and we had to leave them in their teams, and we did not know. So that's why it was very important that the training that we had was from basic to more advanced. So for those that had no epi background, we started from scratch.
Thank you. So speaking of integration of new partners, if you will, into the DIS work, David, I'm going to turn to you now and ask, we talked a lot about engaging with communities and new partners. How should marginalized or disenfranchised communities be involved in the shaping and the construction of our DIS work?
And they have to be involved at the very beginning. Because there's so many complex issues and challenges that communities are faced. And oftentimes, by not engaging them at the very beginning, we design our interventions and put together our teams that don't necessarily consider those issues. And I like what Matt Golden talked about, the interdisciplinary team, because that's exactly what communities need, because they need an epidemiologist, they need community health workers, they need mental health specialists, they need physicians. There's a whole host of things that they need, and people that can link them to services. And the only way that you get at that is that you've got to engage communities at the very beginning to find out what those issues are, what the challenges are, and even more so, what the services and who they need to be working with, because there may be a service provider within their community, but they don't have a relationship with the community and the folks don't like dealing with them. And so if you don't have that in mind, then what you'll end up doing is linking people into care providers where they have no relationship, or the relationship is so bad, then your credibility is shot.
Thank you.
Joe, could I interject something here? I think one thing that we want to make sure we're doing, and I think really gets at what David was saying, is we should be hiring our DIS substantially from the communities that are affected by the health problems we're trying to address. And that will enhance our workers' effectiveness. The other thing it does is that it gives people a job that pays pretty well. Typically that pays better than the jobs they have working at CBOs, and that comes with health insurance and union benefits. And, you know, I mean, the goal is not to offsource all of this work to a workforce that does not get a living wage.
So building on that comment and talking about in most health departments, the DIS function, I think you've already spoken to that as separate teams and sort of how impractical that is for the comprehensive approach we need to undertake. What are your recommendations for reorganizing that kind of work? How do we move forward as individual local health departments in this sort of integrative approach, and including the communities as well? Matt Golden.
No. Well, I think an important first step is you have to say, what's my priority bodies of work, right? And, you know, obviously we have what I think will be an expanding workforce, but we still aren't going to be able to get to everything. It's not going to happen. So we're going to have to decide where can we make the most effective investment of our resources. And then we want to develop teams that can be effective at doing those priority activities. And then we need to be able to be honest with ourselves in the assessment and say when our original decisions were wrong. And it turns out you chose this as a priority body of work, but actually it didn't pan out. Or maybe it worked for a little while, but it isn't a good idea anymore. And I feel like that's a little bit what's happened with a lot of the work we've done. We're doing a lot of the work, maybe it even made sense 30 years ago, but it doesn't necessarily make sense as our priority activity now. And so we're going to have to pivot. And so probably that means in some ways a more robust scientific infrastructure to do these evaluations as well.
Thank you. So Matt Hogben, related to that, you know, we like to think of ourselves as a data-driven program. So what do you think, what are your thoughts about real-time data access? How quickly do we need to have this kind of information to make the kind of decisions that both David and Matt Golden are speaking to?
Well, some of this comes from experience with the working on the pandemic response on it, when I was sort of thinking about this in the first place. And some of this comes from sort of our old sort of, perspective that you can't do certain things in a timely enough fashion to affect an investigation right now. You know, can the data get here? Right? But I think a lot of that has changed. And I think we've seen some of that with COVID, where you have daily updates. It has taken an enormous amount of surveillance resources, and I think some places have the resources and the prior capacity to do that much more easily than others. But I think you can use data much more quickly to inform investigations now. And I think you can use some analytic approaches to inform more investigations now in a sort of a real-time fashion. And other aspects of helping to sort of using data to build that portrait of your community. And I think I'd harken back to those of you, everyone who has talked about what is effectively like an iterative approach, right? Some things work for a while and then they don't work. And you don't know that, of course, unless you're continually checking. So if those data streams are then built into the management of the program and then to the evaluation of the work in the program, and you have hired people who are flexible and whose flexibility and initiative is rewarded, and then we can continue to make some of these sort of leaps forward in our ability to have a sort of a flexible, responsive program on it. I mean, I'd be happy to hear from people who are more closely involved with programs than I on how they've managed this.
Well, I was going to ask Lucretia that. How do you manage that incoming data, and how do you make the kinds of personnel decisions you would have to make to be a nimble program that's sort of really data-driven?
That's a great question. In New York, there were a lot of demands on daily data, what was going on, but as things changed, and a lot is politics. So even though from a public health standpoint, we knew at a point it made no longer sense to keep investigating every case to ask where you went. Once it was documented that it was community acquired, we had to go to the next step and put in other interventions and measures. But sometimes, how can I say this? Decisions are not based on public health, and you have politicians at City Hall making decisions. And as much as we said, here's the data, this is what it shows, this is what we think, a lot of it was out of our control. And that was a challenge we had in New York, even though we had the data and the demands was, they had to get it to them. No one listened to how we interpreted it.
Well, data can be not just the surveillance data that we get from our cases, it can be monitoring the political climate you're working in and the other challenges as well. So I'm going to turn to David now to talk about community engagement and how then do we bring that kind of data into the equation? How do we get the kinds of information that we need from community partners who are not necessarily used to the epidemiological approach, shall we say, and how do we get their data involved in these discussions?
Well, I think to something that Lucretia was talking about, where you've got politicians really impacting your decision, but if you've got key stakeholders in your community that have connections with these so-called leaders and politicians, they can really push that narrative about what really is a priority and what is actually needed and get that data to those decision makers. And so it minimizes, say, public health having to have that battle with leadership and guiding them when you've got your partners and key stakeholders that have connections in the community. And also this drives the point of, when I talk about key stakeholders within the community, I'm talking both public and private sector. And you've got people in the private sector who are working in these communities or invested in these communities that have a responsibility and a desire to make things better. And they also have connections with folks in leadership that then can push that narrative from the community perspective that may help Lucretia make her informed decisions based on the data and minimize her having to have that battle with politics.
Thank you, David. Matthew, you look like you want to make a comment.
I do. I just wanted to sort of tie a couple of points together here. David, you brought into my thoughts again, that I like the idea of sort of programs living in this flow of data and generating it and all that iterative function. But I do want to emphasize that flow of data, right, has to be hand in hand with that meaningful investment in communities that David Kern mentioned on it, and this community engagement. Because if you don't have the community engagement, you don't have the community buy-in to it, then you're just another data source, another sort of big brother surveillance system, right? You could get very good at that and not come across very well. I think there are some social media giants who have grappled with that issue or not. All right, but if you have the community buy-in and you're with the partnerships and the collaborations that we've sort of seen people talk about today, then it becomes a mutual enterprise, and you have this common goal of prevention and control of sexually transmitted disease, HIV, COVID, what have you, and we're all working together kind of on the same team, and hopefully don't feel too bad about the use of the data or providing the data.
Thank you. So I'm going to build on the question now of just sort of if we have good data and the good communication between all the partners, internally and externally, and we move to these field interventions. I want to ask you, Matthew, and others may want to comment as well, about field interventions. What does that need to look like in your thoughts, and how do we ensure that they are achieving the objectives that we would hope that they would? When we talk about field interventions such as expedited therapy and specimen collection, prevention assessments, there's a number of interventions that we do. So let's talk about what they might need to look like, and are there implications based on being data-driven and data coming from multiple sources, how those things should occur. Matthew Hogbin. Sorry, I need to remember that.
No, surely been gone. There are many people who can speak to these issues, right? And I would hope that as we move toward the type of DIS team, right, or the type of disease intervention team, right, that we've sort of spoken about so far on this panel, that we would maximize the ability of DIS to provide interventions in the field. And I think particularly if you are either working with a population that would like to be one and done, something on those lines for it, people you're not likely to see again, or for that matter, that would be a benefit to the program and a benefit to the individual receiving the services if we could be one and done, right? So expediting partner therapy, say for uncomplicated infections, seems like one of those things. And whether you're bringing that out into the field as a DIS, whether you're overseeing and monitoring a program out of an STD clinic or a selection of retail health clinics, et cetera, those skill sets, the skill sets necessary to get those sorts of programs happening where you are going to reach a lot of people, improve coverage, I think, for partners in this, with this example. I think those are good skills, and those are essential builds for a program. We have talked, I would say one other sort of hook piece for it are the issues of who can and cannot do phlebotomy, which I realize is not simply about the training. There are also sort of policy issues in and around that. But if you have DIS who can draw blood, administer injections, and I've heard from Pennsylvania, you know, it kind of depends on who the DIS, public health nurse, public health advisor for it, the extent to which those sort of skills can be and those sorts of capacities can be there in a DIS team investigating the field, I think you can get stuff done and wind up getting stuff done efficiently and then reserve your powder, as it were, for where it's needed most.
Thank you. Matt Golden, so envision that interdisciplinary team conducting the kind of work that often needs to happen in the field. What are your thoughts about that?
Well, I mean, I think there are things you can do in the field and there are things you can't do in the field. We can test in the field for bacterial STIs. We can treat in the field, although giving the injections, frequently there are legal impediments to giving people injections in the field in terms of how the licenses work. And I think that may vary from state to state, what somebody's allowed to do without direct medical supervision and what direct medical supervision is. But for a lot of the things we do, it's more complex than that. So particularly for HIV, which is a chronic disease, you know, what we really, I think, are moving toward is that outreach team is working in collaboration with the clinical services, which need to be reorganized to ensure the effective treatment of everybody. And that in many of our jurisdictions, we've done a good job getting a lot of people treated, and the people who are left behind are probably not going to succeed consistently in conventionally organized medical care. And rather than persist in the fiction that we are going to change them, which we won't, we need to change the healthcare system. And, you know, the TB people are good at this, actually. They've done a lot of directly observed therapy over many years. So maybe they're a model for how we need to think about some of the field services and things along those lines. You know, COVID has been a big lesson, I think, with this. I think Dave Kern talked about this some, and we've certainly done this. I know San Francisco has as well. A lot of what you're talking about is linking people to support services so they can stay home. And that's about groceries, and it's about rental assistance, and a lot of things like that. Not everybody needs that, but some people need that. And probably in New York, you guys were doing this, Lupita, as well. And we were in Seattle. Of course, it's very uneven, I suspect, in the United States as a whole.
Thank you, Matthew. And I was going to ask you, Lucretia, what are your thoughts about these field interventions, and particularly these structural interventions too, in addition to the sort of classic interventions that we think about for STI prevention and control, but as we've all addressed this notion that there are broader issues to address as well.
Yeah, so with the staff that the unit that I oversee in emergency surveillance, it's not a lot of field intervention component to it. I mean, on a regular basis, routinely, staff do go out in the field. They go to make home visits and do health education one-on-one. They do a lot of health education in like houses of worships and community organizations based around travel health. So going in a lot around West African community and malaria. So they do have that intervention, some experience in the routine work. With COVID, in the city being so big, they hired just whole new teams of staff that did that outreach work and was doing that because DOH staff was so involved in the other work inside. So we really didn't have much. But then again, my staff, like in Ebola, I said they did have to go out to interview the travelers when we couldn't reach them for 21 days. So knocking on doors late at night, trying to make contact, to get temperatures and stuff. So the staff supervise our field staff. We changed our name from field services because of the connotation to surveillance and investigation unit just with this COVID activation. So they are comfortable, they are trained. My staff is very diverse and most of DOH, so we have staff that if it's this community that we have someone who speaks the language that could go in, it's people from that community, and that's how we organize for field interventions.
Thank you. So David, thinking back on all of your previous work as a DIS, and as we are charting a course going forward, especially as we talk about field interventions and these interdisciplinary teams, what are your reflections? How might this have really informed your work or improved your work before we got to this space where we were all sort of pointing in this new direction and this paradigm shift?
Yeah, I mean, you bring up a good point, and I think, well, there's a couple of things, actually more than a couple of things. One being, and I'll stay within the realm of STIs, more training just about sex and sexuality and relationships and the complexity that's associated with that, because especially as we have moved away from the so-called heteronormative kind of thinking and approach, but early on really had no concept at all about sex and sexuality. Now, with that said, the other complexity associated with that, especially dealing with very young people, that being Black and brown, on the whole issue around adultification and the sexual abuse, which then leads to some other issues, and really not really having a good foundation and grounding in that. And so it's those kinds of things that communities are faced with, that we provide no real training or guidance and direction. And then we encounter these things and we're not really prepared or ready to deal with that. And especially now with COVID and other issues that are propping up, we've got to better prepare the so-called frontline staff to deal with those complexities that people are dealing with on a day-to-day basis in communities.
Thank you. So although we have an hour for this session, I've actually exhausted my submitted questions. So what I thought I would do is just give each of the panelists an opportunity to make a final comment. And I'm going to start with the first name on the screen I see, and that's Matt Golden. And then we'll move along.
Well, I mean, I think we've had a productive conversation today, or the start of a conversation. I do think that we all need to be thinking about how this workforce is going to be modernized. And the components of the modernization include what work we want people to do, who we want to do it, and how we're going to train them. And I thought David's comments were particularly helpful in that regard in terms of all these soft skills and how important it's going to be to impart those to people, but also how we're going to have to be very careful in our hiring. Because I don't doubt for a minute that we can improve upon your soft skills and communication skills. But if we didn't hire the right people to begin with, it's going to be a tough road. So I would say we want to be careful on that piece of it. I think there's a lot of opportunity for use of new technologies to try to improve on the kinds of work that we're doing. I think we need to be open to very different organizational structures to how we're organizing the work. And I guess my last thing would be, I do not believe these field investigation teams can be successful if they don't have a stronger link to the clinical infrastructure in their cities. That we just don't exist in a vacuum, and the DIS can't do this without a strong public health infrastructure and a strong clinical infrastructure.
Thank you, Matthew. Matt Hogben.
Thank you. So I'll conclude with, I think, one very specific point and then maybe one broader point for it. The specific point is to include social context for an area in the data, if that wasn't clear enough already. But I know someone today, at least one person has mentioned food insecurity, for example. And those data are available. They take a little bit of searching, but there are plenty of places that aggregate them already. And I think knowing something about your area in that sense, right? It's informative for STD prevention and control, but I mean, it's even more informative for the people practicing that. So I would include that in whether you call it surveillance formative work or whichever form it takes. The broader point, and as we look forward to modernization for it, I wouldn't want to lose, I am but a youth of 52 summers, but I would not want to lose sight of the past for it entirely. And so I would bear in mind what we can learn from the past that is worth carrying forward.
Tech gods have messed with Matthew.
In particular, I was thinking of words when I first started.
Matthew, I'm sorry, something happened and you froze. And then when you came back, it was rapid fire. So maybe if you could go back to your broader point and start.
Okay, yeah. Did you get the age in there? I saw somebody's.
We got your 52.
All right,
summers.
There we go. All right, really the rest is gravy. It's what we might learn from what we would continue to carry forward from the past and past operations in this area. And it put me in mind a little bit when I first started at CDC. John Potterat was going to do the treatment guidelines chapter, or he was definitely there in the meeting. And we were talking a bit, and he was talking about the need for DIS to be able to study their communities and know something about the communities in which they were working. So I think that's good advice. I think we've heard that advice moving forward today. I think we should absolutely take it.
Thank you, Matthew. David.
Yeah, I think, really the bottom line is that this is broader, and public health is everything in our life. And it is just not in the clinic. It's just not in the health field. It's everything. Because for example, with the cholera outbreak that happened, they had to clean up the sewage systems. I mean, so what we have to do is have a broader approach to public health and look at broader issues that drive it. Again, as I had mentioned about food insecurity, and now with the eviction issues, you're going to have other issues around housing that is going to impact on public health. So with public health, what we've got to be in mindset with, it's everything, because everything impacts on public health. And if we don't have that global kind of mindset and perspective, then it's all for naught.
Thank you. Lucretia.
Okay, so I agree with what everyone said. I guess some things that just came to mind is, the big picture. So just looking at structural racism, something that was so obvious to me with COVID, because I also worked at the vaccination sites. And in New York City, they rolled out, okay, you can sign up at this link, and not aware of how many communities of color and marginalized people don't have the technology. So they would sit back. I live in the South Bronx. The clinic is not far from me, but it was not the people of the community showing up for vaccinations. And so when they talk about the low vaccination rates in the beginning, how did they expect people if that's the only means of getting an appointment? And it was just, you know, shocking to me. It took so long for them to decide, we'll roll out an 800 number for those who don't have access to the internet. So it is true. We have to look at those bigger, broader issues. We have to hire a diverse staff from the communities where we know disparities lie. And another thing I forgot to mention before, I wanted to say, at the Department of Health, I'm on a task force on standardizing and improving how we collect race, ethnicity, and SOGI information. That's sexual orientation, gender identity. We've been working for 3 years to come up with ways to ask it. And it was a big thing, training all these 400 staff that this is how, and explaining definitions, because unless you ask the questions correctly and understand the data we get, we won't see those disparities. And how can we intervene if we don't know where the problem lies? So that's the point I want to add. Thank you.
Well, thank you. And thank you, panelists. It was a very, very helpful discussion, and I think a very important one. So it looks like you guys are going to get some time back to maybe stretch before the next session, which I believe will begin at 4. So, or maybe this is the end. So maybe you get a short day. So, well, thank you. It was a great panel, and it was my pleasure and privilege to have a chance to moderate it. So I think I turn it back over to the organizers now.
Thank you, Joe.
Thank you.
Very good job, everybody. Thank you so very much for all the presentations today. That's right. Thank you, Joe, for a wonderful panel discussion. I can't believe we are 20 minutes early, but we are. Please enjoy your evening. Please be here tomorrow at 11 Eastern sharp. Look forward to seeing you and tomorrow's discussion. Thank you. Bye.